To give this talk, I invite Professor Premada.
Thank to everyone. This topic about GFR measurement, as we all know, in cancer patients, it's always difficult to measure accurately the GFR. Unfortunately, we need accurate GFR to appropriately dose the chemotherapeutic agents to reduce the nephrotoxicity. So to talk upon this particular topic, I call upon Dr. Priyamada, who is the professor of nephrology at Jibmar Hospital.
So, thank you, chairpersons, and good morning, everyone. It has long been known that patients with CKD have an increased risk of cancer. Reasons were not known. It was attributed because of advanced age, or probably the coexistence of risk factors like diabetes, hypertension and all, which actually the prevalence increases as people age. But large population-based surveys have shown that CKD is an independent risk factor for cancer. And a good majority of the patients with CKD, maybe around 15 to 40%, will have one or other stage of CKD, mostly CKD3 or somewhere around CKD2 to CKD3. And the other way around is also correct. Patients who are diagnosed with cancer, hitherto unknown CKD, they eventually might develop CKD in future, and the mortality is also, for those who develop CKD, the mortality is also going to be high. And we all know that many of the cancer chemotherapeutic agents have a very high risk of nephrotoxicity, and the AKI prevalence can vary anything from 18% to 50% depending on the clinical situation. And it could be cancer per se, or because of the complications or the metabolic or paraneoplastic issues associated with cancer. And disturbingly, there is an increased risk of chronic kidney disease after cancer survival. And even in children who traditionally lack all the conventional risk factors of CKD, around 0.5% of hematologic malignancy survivors, pediatric hematologic malignancy survivors, eventually develop CKD in the long run. Now, many situations, an accurate estimation of the kidney function is going to be absolutely essential. For a day-to-day purpose, we need it for drug dosing. And many of the drugs have renal toxicities. Many of the drugs have a very narrow therapeutic index. Many drugs needs drug modifications, prescription modifications in kidney failure. That's the most important indication. Then in genitourinary malignancies, we need to decide, depending on the GFR, whether someone should go for a complete nephrectomy or a partial nephrectomy. Then creating continent diversions in bladder cancers. Generally, continent diversions using an ileal pouch is contraindicated with low GFR because of the metabolic complications. Then they might actually need repeated episodes of contrast administration, and we might actually, even if it's not a genitourinary malignancy, we might need some surgical planning, preoperative planning in patients with solid organ malignancies in other places. And sometimes it's not uncommon to find patients who is completely wasted, where the creatinine is going to be very low and it's not going to give you any information. And most important, oncology is an emerging field, and probably a lot of clinical trials. That's an area where a lot of clinical trials are happening right now, and recruitment into clinical trials, because most of the clinical trials will have a cutoff of 60 ml or so. So that's basically, I would say, the most important area where we nephrologists has to intervene, because a 59 would make one ineligible for a clinical trial, whereas 61 will make them eligible. Now, from our day-to-day practice, apart from the clinical trial, most of the time we are going to get called in a patient with kidney failure, and we are being asked what is to be the drug dosing and drug adjustments done. And those small molecules that are eliminated by glomerular filtration, and there might be larger molecules that are eliminated by tubular secretion. So both are going to get compromised when you have kidney failure. The second thing is many of these patients with nephrotic syndrome and cancer, because of the hypoalbuminemia, the plasma protein binding of the drugs are going to be different. And sometimes the free fraction of the drug might be pretty high. So even within the permitted therapeutic range, they might be vulnerable to toxicity. And people who are uremic, many of these drugs and uremic solutes might compete with the drug binding sites of protein. And so many surveys have shown that at least 80% of the patients with cancer, they might end up getting a potentially nephrotoxic medication, or they might have received a drug that needs dose modification according to their GFR. Now, this actually shows what has happened to the GFR measurements in the last 50 years. And you can see that Cockcroft-Gault formula was the only way to assess the kidney function for quite a long time. And in 1998, the Cockcroft-Gault formula was incorporated in the FDA guidelines for dosing of anti-cancer drugs. So that is why even today, Cockcroft-Gault formula is so popular among oncologists, and it's not uncommon that your oncology colleague might send you a reference telling that creatinine clearance is 56. Kindly advise on further management. The one reason is the lack of research on the other new formulas, and we know that all the other EGFR formulas are pretty new. 1999 to 2006 marked the evolution of the MDRD formula, which subsequently became replaced in a couple of years by CKD EPI. And then again came the CKD EPI cystatin equation in 2012. And now 2021, as of 2021, we have a new CKD EPI formula. So basically, the GFR assessments for us nephrologists has actually changed quite a lot starting from 2005. And unfortunately, because of this change, focused research actually has become a little bit difficult or troublesome, and when you look at the data and compare, that becomes even more difficult. Now we know that creatinine is not the best marker. The problems with creatinine you all know, I'm not going to be elaborating on it. Cystatin C is said to have, not to have many of the issues related to creatinine, but the problem is it could be increased in thyroid, it could be increased in hypothyroidism, and it could be reduced in hyperthyroidism, and corticosteroids can also affect cystatin C. The problem with cystatin C till recently was the lack of standardization in assay. So one lab would give one cystatin C and other lab could give other cystatin C. So creatinine will have some more. Creatinine is already a marker with a lot of issues, but creatinine will have a little more extra issues when it comes to cancer because of sarcopenia. As patients have cancer, as they progress towards in cancer, the prevalence of sarcopenia increases. And it has been found that at least 1 in 5 patients at the time of cancer diagnosis will have sarcopenia. And by the time actually they pass a year on cancer, it might be 70 or 80%. So that the creatinine basically for them might be 0.2 or 0.3. And you're going to miss the AKI diagnosis if you actually want the creatinine to go above the upper limit of normal for the lab. And again, when actual creatinine clearance is measured by 24-hour urine collections, it has been found that 15 to 40% of the patients who have a normal creatinine assay by Jaffe's method or modified Jaffe's method, whatever, they will have reduced creatinine clearance. Now there's another issue which is happening in cancer, which might be easily overlooked. That's something called an augmented renal clearance when cancer gets complicated by a critical illness. There is no standard definition for augmented renal clearance, but traditionally a creatinine clearance of more than 130 ml per minute is considered as augmented renal clearance, even though you might actually see definitions putting it down to 120 ml also. What is the actual reason for augmented renal clearance? Nobody knows. It is believed that probably the hemodynamic changes associated with the critical illness. IV fluids might be contributing. Some of the inflammatory mediators associated with the critical illness and sepsis might be contributing, and there might be inflammation and probably a brain kidney crosstalk. So as a result, what happens is, we know that the entire surface area of the glomerular basement membrane is not used for filtration. At some point, the pressure gradient becomes zero. The capillary hydrostatic pressure favors the filtration, whereas the oncotic pressure opposes. And there is a minimal amount of tubular pressure. So all these three forces, at some point it becomes zero and filtration stops at that point. And when you have major hemodynamic disturbances in the glomerulus, the point at which this equilibrium is reached, that shifts further, which means that a lot of glomerular capillary area is available for filtration. And also, it is believed that there might be enhanced tubular secretion of creatinine. The consequence is that, see, if this patient develops AKI, because of the augmented renal clearance, their creatinine already might have gone down. And you are likely to miss AKIs in these patients. And more important, we really do not know how to estimate the glomerular filtration rate in these patients, because this is a completely gray zone. And more important, there is a real chance of suboptimal drug dosing in these patients. Now this is some data. The yellow lines, the yellow bars represents augmented renal clearance. This is actually data from patients who spend their time in ICUs, and you can see that maybe around 20% or 30% of the patients, they will exhibit this phenomenon of augmented renal clearance. And cystatin C, is cystatin C the answer? Because you know that creatinine is not going to be a good marker in normal individuals, and it has overall more problems in cancer. So can we replace it with cystatin C? Probably not, because cystatin C, we know that it's secreted by all nucleated cells at a constant rate. So it's very well possible that the malignant cells also might be secreting cystatin C. And possibly there might be certain chemotherapeutic agents which can actually affect the cystatin C. And again, this is a gray zone, whether which agent increases cystatin C, which agent reduces cystatin C, we don't know. But it is believed that probably many of the chemotherapeutic agents can interfere with the cystatin C metabolism. Now, this is actually, and another thing which we need to remember is, in 2010, IDMS was introduced as a standardization method for creatinine. And that has made some implications in the serum creatinine. And when we use a method traceable to IDMS, compared to the conventional Jaffe's method or the modified Jaffe's method, what we are getting, the creatinine we are getting is 20% lower than what it used to be. And you have to keep in mind that the Cockcroft-Gault equation was actually derived, tested, validated with the old creatinine equation. Now, when you use a method which is standardized to IDMS, the Cockcroft-Gault equation derived creatinine clearance need not actually reflect the actual glomerular filtration rate. And this is a study which has been published in 2009. Well before the standardization was introduced, and what they did was they compared the Cockcroft-Gault formula with the MDRD 1 and 2 equations. These equations are not very popular, and it was actually abandoned shortly after it was developed. And it is shown that Cockcroft-Gault has the best reproducibility, best correlation compared to GFR measured by chromium-51 EDTA. Now, again, you see that the correlation coefficient is only 0.63, which means that a good majority of the patients with cancer will have a false value with Cockcroft-Gault formula. And again, it has been shown that measured creatinine clearance predicts completion of cystatin based chemotherapy, but not with the Cockcroft-Gault formula. And in obese individuals, probably Cockcroft-Gault formula is going to overestimate the GFR. So it has been shown that when you're using the Cockcroft-Gault formula, instead of the actual weight, you just use the ideal body weight for that particular age plus give an allowance of 30%. Now again, this is another study which was published in 2012. And again, it has also shown that compared to MDRD, the 4-variable MDRD, Cockcroft-Gault formula actually has the least bias. Like, it gives an estimate closer to the chromium-51 EDTA. But again, this study, even though published in 2012, the recruitment happened somewhere around 2003 to 2006. So basically, what I just wanted to say is, if we see older literature telling that Cockcroft-Gault formula is correlating best with the actual measurement of GFR, either estimated by chromium-51 EDTA or iothalmate clearance, there is an analytical factor that has contributed to that. And now, with the recent assays, IDMS standardized assays, we can see that CKD EPI, actually the performance is not very great, but among all these various formulas which estimate the GFR, CKD EPI has the best performance. And again, this is a recent study which has compared different equations with inulin clearance. You know that inulin clearance is very difficult to do because because of its difficulty in procuring inulin, doing it, most of the studies, either iothalmate or chromium-51 EDTA will be the reference. And this is the only study I could find where they have tested against inulin clearance in Japanese patients. And what they did was, what they found was CKD EPI, basically they added a small modification to CKD EPI that had the best reproducibility. And again, another important question is, when we express GFR in patients with cancer, should we express it as GFR in ml, not index to the body surface area, or should we express it as index to the body surface area? When your test patient in which you are testing the GFR has a normal body surface area, this does not make any difference because already the body surface area is 1.73 meters square. Now you are dealing with a patient with a higher body surface area. The absolute GFR will be higher. Now, when we index it to 1.73 meters square, the GFR would come down. And the exact opposite happens for a person who is underweight. So, another lingering question is, we know that all cancer chemotherapeutic agents are indexed to the body surface area. The idea is to give the maximum tolerated dose. Unlike antibiotics where you have a range and you are free to decide in between the range, cancer chemotherapy rests on one hypothesis, that is, you give the maximum tolerated dose, and all the doses are actually adjusted to the body surface area. So this was a question which actually people were pondering over quite some time, because if your body surface area is quite different from an average adult, the dose of the drug received will be dependent on how you actually decide whether to index it or whether not to index it. And again, I'm coming to that at a little bit later. So the final verdict about the Cockcroft-Gault formula is, Cockcroft-Gault equation is less accurate in obese and the elderly, and the accuracy is questionable with IDMS standardization because absolute values have changed. And another big issue with the creatinine clearance is it's not indexed to the body surface area, whereas drugs are indexed to the body surface area. That might create confusion when deciding on the drug dosages. And overall, the recent literature after the IDMS standardization, there are a lot of small studies, and unfortunately, there's no systematic review or meta-analysis, but almost all these studies with limited sample sizes agrees on one thing: CKD EPI formula is the best after IDMS standardization. And again, actually, in the Cockcroft-Gault era, people have tried to working on some cancer-specific equations. And actually, these are all modifications of Cockcroft-Gault equation. But again, all these equations are validated in small studies with, say, 100 or 150 number of patients, and they have not been internally or externally validated. And this is actually like a recent study which has been published with quite a good number of patients, maybe around 2,500 plus patients. And what they found is, there's no pointer, right? Okay. So what you can find in this panel is the scatter. We can see a lot of scatter when we actually compare all these formulas with chromium-51 EDTA or iothalamate. That scatter is going to be normal. So what we consider is the one with the least scatter is going to be the best. And now you can see that what they did is, they proposed a new model. Basically, it's a modification of the CKD EPI formula. And this new model actually had the best correlation with the measured GFR, and they had validated this in an external cohort also. Now, without this new model, the best reproduction was with the CKD EPI adjusted to the body surface area. So that part is clear. You have to adjust to the body surface area when you express GFR in cancer patients, because this type of data is very difficult to get in onconephrology, because if you see the literature, most of the studies will be 50, 100 or 150, and it's very hard to find a study with 200 plus individuals. And this is something which actually has undergone an external validation as well. So nowadays, there is a tendency, the name of the first author is Janowitz, and there's a tendency to use this Janowitz equation. It's otherwise called the Janowitz equation. Now, unfortunately, professional societies in oncology has not come up with any recommendation. The only recommendation available is as of 2007, and you know that it's no longer valid because things have changed, equations have changed. And there might be a few potential scenarios for all practical purpose now. For all practical purpose, you can use the CKD EPI formula adjusted to the body surface area. Or if you want to be a little more specific, you can use the Janowitz equation, which basically is a modification of the CKD EPI. But again, Janowitz equation is not tested in other people with other ethnicities. That's a problem. So we don't really know how actually people with South Asian ethnicity is going to perform with these equations. But there might be certain cases in which you will have to go and measure the GFR. So one is genitourinary cancers, basically to help you in deciding the surgical management, and cisplatin-based chemotherapy. That's one of the most toxic chemotherapeutic drug, and sometimes actually many solid organ tumors, there's no regimen without cisplatin. So a borderline patient with a, like say 58 or 59, possibly to decide on whether the patient becomes eligible to cisplatin-based chemotherapy, probably will have to go and measure the GFR. Now, coming to the future directions. So basically, glomerular filtration markers and lots of new markers and new methods are being added on a day-to-day basis. None of this has been tested in malignancy, but these are possible markers that could find appropriate testing in cancer patients at a future point of time. So basically, there is this new 4-panel GFR, which incorporates creatinine, cystatin C, beta-trace protein, and beta-2 microglobulin that has been found to have a better performance compared to the conventional CKD EPI equations incorporating creatinine and cystatin C. So this is one future direction. The problem is beta-2 microglobulin and beta-trace protein have issues in cancer, but this needs further testing. The second thing is actually like the problem with measuring the GFR, it's a cumbersome process. And we need chromium 51 EDTA, and it's very difficult to get the isotope as of now in India. And iothalmate, probably not many centers are doing iothalmate also. So this is something called a point of care monitoring system for measuring GFR. So basically what you need to do is you have to inject a dye, a fluorescent dye, 150 kilodalton rhodamine derivative, which is not filtered because of the larger molecular weight that is confined to the vascular space, and you have another fluorescent tagged carboxymethyl dextran, which is a small molecule which is filtered. So basically, we can track the disappearance of this 5 kilodalton fluorescent carboxymethyl dextran by taking a series of blood samples, and this is a countertop analyzer that would actually analyze the fluorescence, and by plotting this against the disappearance of this marker, we can come to the GFR, and it actually shows a very excellent correlation. You can see the regression plot telling that, like you can see it's all close to the regression line, so almost near, like it's like close to 1. It's 0.99, it's almost close to 1. And this has been tested in human volunteers, but not in malignancy. But this is one possible research area which could be developed subsequently. And now this is something which is tested in animals, not in humans yet. So basically the principles are same. Here instead of the blood sample, you can actually, with this equipment called MediBeacon, you can actually look at the disappearance of this tracer from your body. You need to keep it close to the animal. So these are two point of care GFR measurement devices which is being tested and which possibly might come up in the future. The other thing which is coming up, the application is limited to renal cell cancers, is basically the renal parenchymal volume assessment to predict the GFR at a future date. So after nephrectomy, we all know that the other kidney compensates, and after a couple of months, say sometime 3 to 12 months after nephrectomy, the patient will stabilize at a new GFR rate. And already there are formulas based on the size of the remnant kidney as well as the split renal function assessed by DTPA. So what here the authors have used is, you look at the third panel, they have used machine learning algorithms to predict the future GFR, and it actually has a much better performance compared to the GFR predictions using the size of the remnant kidney, the other contralateral kidney, as well as it predicts better compared to GFR measurements based on this isotope measurements also. So possibly this is another area which is likely to develop. You know the kidney volumes. You can use a program to subtract all the other connective tissue and other things, and you might be able to find out how much is the glomerular volume, how much is the renal tubule volume, and you can convert it into a meaningful figure. These are all too early research, and probably there's a long road ahead. So as of now, there is no evidence-based recommendation on kidney function. Based on available literature, CKD EPI formula, creatinine equation 2009 index to the body surface area is having the best performance. Janowitz has come with a modified equation, but that needs to be tested in other people with other ethnicities. And you have to consider actual measurement of GFR in certain situations where you have to take a decision on nephrectomy or whether you are dealing with genitourinary malignancies. And another big problem is we have algorithms based on creatinine clearance but not on estimated GFR. So basically, it needs a judicious clinical assessment, individualized approach, constant re-evaluation, and communication with the oncologist how to proceed.
It's a very good lecture we have listened, madam. A lot of things are open for discussion. but due to shortage of time, we cannot ask many questions. Only one question I want to ask you, madam, before the floor is open for discussion. Many a time, my colleagues, they don't have much belief in measured GFR, creatinine clearance.
Yeah, actually, the problem is what measured GFR is available to us is DTPA. And DTPA has a lot of fallacies. And actually, I have tried getting chromium 51 EDT. It's very costly. It's very difficult to get. It has a very short half-life. So if you ask me whether I would recommend DTPA measurements as a surrogate, probably not. Okay, like if I get a DTPA measurement of, if I have a patient with 58 GFR and I get a DTPA measurement of 63, well and good. Okay, I will be happy. But it's very, DTPA has a lot of scatter compared to chromium 51 EDTA. I have done some work in some other scenario with the DTPA. The problem is the scatter is too much.
A very good lecture as always, a lot of clarity, Dr. Priyambada. I just have one question to you. So you said that as of today, the closest we can get is a CKD EPI.
CKD EPI.
So before that, you showed a slide which said that there was a modification of 0.81. So do we do it into 0.81 and then with the body surface?
That's in Japanese population.
Yes.
Because Japanese population always had separate measurements for GFR. Yes. So we really don't know whether that's going to work in our population. So that's what I told. Janowitz formula had predominantly white patients. And this Japanese modification...
No. I'm talking about one of the slides which you said that there was
0.813 into CKD EPI.
Yes.
That's specific in Japanese patients.
Only Japanese. So for
45 patients only. 45
okay.
patients
so for
only.
our population, we just...
I think actually, in the absence of any population-specific thing, we should stick on to CKD EPI.
With the BSA.
Maybe Janowitz formula, performance in Indian population is something which is actually open for research.
Yes. Thank you.
For the next talk in this session, I call upon Dr. Rajendran sir and Dr. Ramprasad sir to chair the next talk on immunotherapy and spoons and plates in ONCONEPHROLOGY world by Dr. Mayuri ma'am.
We'll move on to our next topic. We all know that immunotherapy such as immune complex, immune-mediated therapies and chimeral antibody CAR therapies have been revolutionized the treatment in cancer therapy, but it is also known to cause multi-organ dysfunction. So specific to renal, we call upon Dr. Mayuri madam. Welcome, madam. I hand over the dice.
Thank you very much, and very good morning to all of you. Right. So essentially, we know that immunotherapy has changed completely the treatment of cancer and the face of cancer all over globally, as well as in India today. We are having a lot of access to immunotherapy, though not completely, but to a lot of agents. The cancer-dedicated centers definitely have a more exposure to these immunotherapies, and as nephrologists who are working dedicatedly in these institutes, we see this more closely. But as we realize that when immunotherapy is becoming more and more common, even the general nephrologist is going to have a lot of these patients being referred to them, and we need to realize that wherein immunotherapy is definitely a boon to cancer, there are a lot of side effects of this therapy, and we still don't have very good algorithms or guidelines which are going to guide us as to when and how we use these therapies or we treat these complications. So as I said that yes, definitely it is a novel thing, and it has become the fourth pillar of cancer care today in our country. And we also know that immunotherapy can be used in metastatic, adjuvant and as neoadjuvant therapy also, and in a wide variety of cancers as of today. Now when I say immunotherapy, we include immune checkpoint inhibitors, the CAR-Ts, the monoclonal antibodies, vaccines and the immunomodulators. But today we have dedicated lectures for most of these topics, and so my topic is essentially going to stick to the immune checkpoint inhibitors. Now, before I actually speak of the ICI, the history of cancer immunotherapy is something that interested me. So we know that William Coley was considered to be the father of immunotherapy because as early as 1891, he started injecting a mixture of bacteria in patients with bone sarcomas, and he saw that these patients, so his thought started with that patients who had secondary bacterial infections tended to do better as compared to patients who did not have sepsis. And that's where this hypothesis came up, and he started dedicatedly injecting patients with cocktails of bacteria, and that's when he realized that there was a chance of spontaneous remission of bone sarcomas in this patient. So this is the genesis of immune therapy for us as in today. Now essentially that just remained as research because the whole thought of injecting bacteria into a patient was something that required a lot of bravery, if I could say that, at that point of time. And of course he could never decipher what the mechanism of action was. So over the time we realized that things like interleukins and interferons and chemokines, and these were the basic mechanism of action for this entire immunotherapy. And the early, the modern immunotherapy, the earliest we know is when we used large dose interferon therapy for stage 3 and stage 4 melanomas, and we used IL-2 therapies for metastatic RCC. So this is one of the early immunotherapy that we know of which was protocolized. Now coming to the modern immunotherapy as we see it today, we have a better understanding of immunosurveillance today with where we know that the innate immune cells eliminate cancer cells in the body, and we also have progressed to a level that we have the Nobel Prize in 2018 for Dr. Allison and Honjo who got it for the immunotherapy that we know today, that we use today. And essentially immunotherapy is maintaining this crucial balance between cancer and the autoimmunity that this immune therapy can cause. So now coming to what I'm essentially going to talk to, that what is immune checkpoint, what does it mean? So essentially it is a process by which various immune system components, they protect the host from primary tumor development, or they would enhance the tumor escape in these patients. And they are essentially cell surface receptors are what they are, and they control either the activation or the inhibition of immune responses. Now wherein we definitely want the activation or inhibition of this for tumor control, we have to realize that it's the same mechanism which can trigger autoimmunity, and autoimmunity is the basis of the adverse effects that you see because of immune therapy. So the immune checkpoint inhibitors commonly in use in India today are we have the CTLA-4 inhibitors, that is the ipilimumab, which was the oldest which was used in use. Then we had the PD-1 inhibitors, that is the nivolumab and the pembrolizumab, and then we have the PD-L1 inhibitors, that is the atezolizumab, avelumab, and durvalumab. There are other drugs which are available. They may not be available that commonly, but these are drugs which we are definitely using in the day-to-day practice, and you would come across these more commonly. Now, so the immune-related adverse events is what I was talking about, that what is the bane of the immune therapy. And immune-related adverse events are, this is what limits the rampant use of immunotherapy for us as in today. The reason being they are challenging to diagnose, they are challenging to treat, and they are also challenging to predict. You cannot predict which patient is going to have it and which patient will not have it. And as of now, definitions for these are also extremely in the gray zone. So at least 15 to 90% of treated patients with immunotherapy will have some kind of an immune-related adverse event, which can be an endocrine, which can be a gastro, which can be a nephrology. So it is, or which can just be a dermatological adverse effect that these patients see. So when you see the numbers, it's as high as 90%. And the overall incidence of these affecting any organ is as high as 86 to 90% in the anti-CTLA-4 agents, and a little lesser in the PD-1 and the PD-L1 agents. Now, since we are in an onconephrology session and I'm a nephrologist, I would be more biased towards the ICI AKIs, and that is seen in around 2 to 5% of patients treated with these agents. Now, when are there any predictors of toxicity? Extremely vague, but we see that patients who have a baseline lymphopenia or who have presence of eosinophilia at the onset of the when the therapy started, or there are rapid changes in the B cell or the T cell repertoire, or if they have high circulating IL-17 levels, or they have the gut microbiota which is changing very rapidly. So these have been hypothesized as predictors, but still not robust data or proven for the same. Now coming to the AKI, so as I said that the incidence of renal toxicity is less than 5%. It's been defined in various literatures 2 to 5%, with grade 3 or 4 is seen in less than 1%. So severe AKI is seen in less than 1%. And the time of onset can be anywhere. It can be early, it can be 3 to 10 months, or 2 to 3 months, or it can be as late as 3 to 10 months after initiation of the therapy. So you can see that it can come anywhere down the line from the first dose whenever it is initiated. And the incidence amongst patients who use a combination of immune therapy would be a little higher than those in whom we use a single agent. Now coming to the definition of ICI AKI. So the National Cancer Institute common terminology criteria for any adverse effect defined AKI as an increase in the serum creatinine level to the upper limit of normal, which is a little too vague if we actually see what the definition of AKI for us today is. And the KDIGO criteria for AKI is very specific. We are used to that. And the whole problem about the ICI AKI is that there are certain studies which take even stage 1 as AKI. There are certain studies who eliminated stage 1 as AKI. They did not take that, and they only considered stage 2 and higher of KDIGO as ICI AKI. So the problem is that there is a need for harmonization of definition. Maybe the incidence that is there in the literature may not be the correct one because we don't have a uniform definition for the same. And we also have to be very sure that what we are calling ICI AKI is actually ICI AKI only, and because there are, as Dr. Priyambada just told us, that there are so many reasons why the creatinine or the kidney functions in these patients may be not normal. Now, the probable mechanism of ICI is again very, very poorly understood, but the hypothesis is whatever has been derived is from the mechanism that has been studied in the extrarenal adverse effects. And there is autoimmunity which is triggered, and most probably the antigen is on the tubular cell, because the most common histopathological or the clinical syndrome of nephrology is an acute tubular interstitial nephritis. They present with ATIN, and therefore it is presumed that it would be on the tubular cell. An alternative hypothesis which is right now being considered is that we see a higher incidence of ICI AKI in patients who have used previous agents which can cause ATIN, like most commonly being PPIs or NSAIDs, and therefore there may be a loss of tolerance to effector T cells which is primed because of the previous drug exposure, say because the patient has received NSAIDs or because the patient has received PPI. Now, the proposed classification of ICI AKI is when the definitive diagnosis is that when you have done a biopsy and there is a biopsy which is compatible to an ICI agent-induced injury, there is an ATIN, and there is no other factor which kind of explains this ATIN. Then there is probable, and then there is possible, and they have criteria which are specific, and these criteria have to be fulfilled for us to call them as ICI AKI. What are the clinical features? There is nothing which can specifically define an ICI AKI, and most commonly these patients present with a sterile AKI with sterile pyuria and a subnephrotic proteinuria. Very rarely, in less than 30% of patients, there may be peripheral eosinophilia. Presence of eosinophilia may not make us, absence of eosinophilia does not make us wiser, but if it is present, it kind of points more towards this agent being the cause. Very, very rarely the patient may present with a nephrotic syndrome. And there is one factor which has been consistently seen in all studies is usually a renal IRAE, that is an adverse event, is associated with an extra-renal which has happened before. So when you are seeing a patient who comes with an ICI where you are suspecting, ask them for other adverse effects if they have had them before, whether they have had dermatitis, colitis, or if they have had any endocrine issues, they are on thyroid supplements which have been recent, because renals are usually associated, or they are preceded by extra-renal features coming first, and then the renal manifestation happens. Now, what are the risk factors? As I said, other drugs which cause ATIN, so use of PPIs or NSAIDs in the near past or concomitant use, combination therapy or sequential therapy with more than one ICI agent, and if the patient has a lower baseline GFR to begin with when we initiate the therapy. Now, coming to this whole, the whole controversy that exists, that whom do you biopsy and whom do you empirically treat? So, again, there are no absolute guidelines or algorithms for this, but on the whole, the consensus is that if a patient comes with stage 1 AKI, so when I say stage 1, I mean by KDIGO, so stage 1 KDIGO AKI, look for reversible other etiologies for AKI, and definitely stop the agent temporarily and see if there is recovery. Should the patient have a persistent stage 1, so when there is no recovery, or he presents with a stage 2 or 3, he definitely needs a nephrology consult other than stopping the agent, and we should strongly consider biopsying these patients. Now, or if the patient presents with a nephrotic syndrome to begin with, then there is no controversy here, this patient should be biopsied. Now, where would you think that you can start empirical steroid therapy? One is if he has, you are absolutely sure that there is no other alternative cause of AKI. And second is that if a patient has an absolute contraindication for a kidney biopsy, so if he has a single kidney or there is a coagulopathy which is going on or low platelets and you are not able to technically perform, whatever, if given a choice, try and biopsy as many patients as you can. So keep your threshold for biopsies low in these patients. Now, essentially, right now, the approach to ICI AKI is that if a patient comes with AKI stage 1, stop the therapy. If it resolves, you re-challenge, continue the therapy. If it persists or it progresses to stage 2 or stage 3, stop, and you definitely need to consider a kidney biopsy if there is no alternative reason for this. If you are not able to biopsy, you empirically try treatment with steroids, and if the patient goes into partial or complete remission, well and good. If he goes only into partial remission at a later stage, consider a kidney biopsy to look for an alternative diagnosis. Now, the histopathology, as I said, the most common is an ATIN, which will be seen in 90% of the patients, and very rarely it is associated with glomerulonephritis. The most common described glomerulonephritis is IgA nephropathy or post-immune glomerulonephritis. Rarely there have been case reports where these patients have come with a normal glomerular structure, so there is a minimal change disease in these patients with a nephrotic syndrome. Now, what is the treatment? As of today, we do not have randomized controlled trials which define the treatment, but glucocorticoids have been the mainstay of therapy, with at least 90% of patients showing a complete remission or a partial remission of their AKI or their urinary abnormalities. And the most common regimen, again, no defined regimen, but the most common regimen that's used is 1 milligram per kg oral steroids, which you slowly taper over 6 weeks to 12 weeks. So over 3 months, you slowly taper it. And in patients who have required hospitalization or who have required renal replacement therapy because of an AKI, you won't be wrong if you use IV MPS. Now, in patients who do not show response to steroids or who relapse with steroids, there have been a few small observational studies which have used infliximab, because there has been the anti-TNF alpha agent, because they have high circulating levels of IL-17 and TNF-alpha has shown to have some role to play in these patients. So essentially, as of now, infliximab is used either for steroid refractory patients or patients who have relapsed on steroids and have had a new onset AKI is where you would consider infliximab. Again, the protocol, how many times do you give it? Nothing is defined, and it is decided case to case. Now, the next question is re-challenged. Can you give this agent again? So if the ASCO guidelines are very clear, they have said that you just stop, if the patient has received, if the patient has severe stage 3 AKI, you just stop, or he has required dialysis, you stop the ICI and don't re-challenge it. But maybe I think we are being a little too rigid about it, and that's what the nephrology literature says, that we won't be very wrong in re-challenging because the withholding the ICI because of fear of recurrence of AKI does not seem unreasonable, does seem unreasonable at present, is because ICI is an agent which is usually a salvage therapy. These are used in patients who are metastatic, or they are used as adjuvant or neoadjuvant therapy. It isn't that it is a first line. So maybe we may go on a lower dose or a increased frequency, but as of now, just making a blanket statement that do not re-challenge would not be right. Definitely, we require more thoughts on this. And the observational studies have, wherein I agree they are observational studies and they are small studies, but the chances of recurrence of AKI is as low as 3 to 5%. So maybe we can decide case to case. And as nephrologists, we have a special consideration for patients of ours who have a renal transplant and then they develop a malignancy which requires immune checkpoint inhibition. So we know that ICIs trigger rejection, and there is a higher incidence of rejection with anti-PD-1 monotherapy or sequential combination therapy which contains anti-PD-1. So we have to be very aware that this agent, so it isn't that you can't use it, but you have to be more aware. You have to do the monitoring much more closely, and you may not be wrong in increasing the doses of steroids temporarily till the immune therapy is going on in these patients, or you change over to the use of sirolimus, or even better to everolimus, because these agents do not, they kind of protect a bit in the triggering of the rejection. And depending on the individual immunology risk of this patient, you will have to decide whether the immunosuppression has to be stopped or reduced. So you would be right in interrupting immunosuppression in patients which are EBV, your PTLDs or your skin cancers, but doing that as a blanket rule for every solid organ malignancy may not be necessary. Now, so just approach to the initiation of therapy. So any patient who is eligible for an immune checkpoint inhibitor, if they are kidney transplant patients, you use them only if that is the only available agent. Try and prefer a non-ICI based regimen. If they are CKD patients, you evaluate their baseline, and every 2 weekly, you will have to look for kidney functions and their proteinuria. If they have pre-existent autoimmune glomerulonephritis, there might be a relapse of this disease. So again, the monitoring has to be very, very close, and the patient has to, you have to have a prolonged and a detailed discussion with the patient about the kidney disease being triggered. And a patient who has no history of kidney disease, I already told you the approach to these patients. Now, institutional data from Tata Medical from Mumbai, we had 16 patients which were referred to our clinic from Jan 23 to March 24 who were on immune checkpoint inhibitors. And the reasons for referral most commonly was a new onset AKI in these patients. The drugs most commonly that we use in Tata was nivolumab and pembrolizumab, with more numbers of pembrolizumab. And the malignancies usually were either metastatic genitourinary malignancies or CA lung is where it was being used. We could do kidney biopsies in 6 out of 16 patients, and histopathologically, all of them were ATIN. We did use steroids in 3 out of the 16 patients, and all 3 of them are right now in partial remission with reinitiation of the drug, and they are stable with their renal functions. So the take-home message, as I said, is that these agents have definitely changed the face of cancer therapy, but we have to realize that autoimmunity is a real-time problem that we are facing in our clinics and at the bedside. And unfortunately, as of today, definitive guidelines and algorithms are lacking. Wherein I understand that cessation of therapy is something that is important, but it may not be the option every time, because that may be the only option for the cancer for this patient. And as we go ahead, we are growing wiser, but we need to collaborate our data, collate our data, and that is what is the need for the hour. Thank you very much for a patient hearing, and I'll be happy to take questions.
Thank you, madam. It was a very elaborate and a very precise deliberation. So as oncologist, we use, as you told, on a regular basis. So I have two queries before I open it up. So you presented the data from Tata Memorial Hospital. So we all know that Tata Memorial is doing a lot of studies on low-dose immunotherapy. That
Yes.
means they've published that the efficacy is going to be the same. So do we have data coming up that the side effects are lesser, or are we looking into low-dose immunotherapy adverse effect profile?
So right now our algorithm in Tata is when we re-challenge the patient, we go in for a lower dose, and then if they do stable, we go back to the parent dose. But as of now, the data is not analyzed. We are in the process of keeping the data, but I'm sure we'll come up with that data very soon.
Very nice. And the second one, you mentioned that it is precluded by the proteinuria.
Yes.
So some drugs like bevacizumab, we actually routinely check for proteinuria. So do you recommend, even in patients with no renal dysfunction to start with, do we need to do routine proteinuria assessment at 3 months or 6 months, or is that not part of the, we don't do it routinely?
Yeah, so the algorithms, even the oncology algorithms have not as of now mentioned, but at Tata, we make it a point to do at least a urine routine and a spot protein creat ratio every 3 months. The first time there is an abnormality, then we start monitoring it every month. So we have started doing that. We will give you the data hopefully very soon.
That will be more practical. Yes, and a cheaper way to monitor. I open it up for discussion. Any pressing questions? Yes, Sandeep.
When you do re-challenge with ICA, when a patients have had AK, say stage 1 or stage 2 or stage 3, what are the specific things you do other than your low dose? You start your immuno at the low dose. Anything else you do differently?
Like you would do it for any other AKI. So, the blanket statements that no other nephrotoxic drugs, and keep the hydration well. And yes, we monitor them a little more aggressively than what we would monitor otherwise a non-ICI AKI patient, because here, if I had to put it bluntly, his life depends on that agent. Exactly. So we better not kind of stop that agent for a reason that was not. So these patients, as I said, these ICI, they are very commonly used in genitourinary malignancies. These patients may develop obstruction at any time. So, these are the things that we are mindfully aware of, that there is no other cause of the AKI, but otherwise nothing that is specific.
So you said, no, these ICI AKIs are actually preceded by colitis, dermatitis, pneumonitis. So how many of your patients, and those are also, let's say, immune-mediated adverse events?
Yes.
So are they on steroids, and despite being on steroids for their colitis and other problems, still they develop AKI? Have you seen any patients like that?
Yeah, ma'am, I haven't seen patients. So I'll be very frank about it, ma'am. We haven't had many patients. So we've started actually using steroids for these patients in AKI very recently, in the last 6 months, or when the data started coming. The most common in Tata that we have seen is the hypophysitis that they develop, and then they are on thyroid disease. They come with the more than that probably would be the non-specific, the dermatitis that they come with. And they are just treated with the topic of stopping the agent and topping. So I have personally not seen such severe reactions where the steroids were used in the non-renal this.
Actually, our hospital has, in Delhi we have some 1,200 patients on ICI AKIs. They see renal not as an important side effect as compared to the...
That's how it is, because renal is just less than 3, but ma'am, this is a nephrology conference.
No, it is coming in, because yes, the more you use, the more it becomes...
I think luckily for us, many of us have not seen AKI-induced ICI, but other things we see much more commonly.
I go back to Priyamvada, because you don't see AKI, your baseline creatines are so low.
That's true, yeah.
So when you really go into creatinine 0.5, like pregnancy.
Yes.
Pregnancy, the level of creatinine at which we say it is AKI is much lesser Compared to
As
normal
ma'am told,
person.
like thyroid dysfunction or the dermatic or the other autoimmune side effects, the renal dysfunction with ICI is much lesser. Yeah.
We miss the proteinuria part also to a certain
Yeah,
extent.
that's true. Yeah, we don't do it routinely. Yeah.
So if I could just ask one doubt that I had. So in one of these papers, they said that patients who developed the immune, the adverse, they did better malignancy-wise. Is that true?
So this is a very interesting and a controversial session. So our main goal is not to use steroids as much because we know that it will blunt the response of ICIs. But there has been very interesting paper where somebody developed grade 3 and grade 4 toxicity, and we had to, as the ASCO recommendation, we stop further IKI. They did actually as well as those who continued for 1 or 2 years. So,
Yes.
that means that they've mounted that much of immune response for us to have a longer. So as you mentioned earlier, there is no randomized evidence, but there's a lot of data coming up that don't get disappointed if you have to stop ICI with a true grade 3, grade 4 toxicity. You monitor them, they may do as well as somebody who doesn't. Yeah, that's a very interesting area actually.
So we wouldn't be wrong in saying that a patient who develops an adverse event because of this agent may do well malignancy-wise. The adverse event is what we stop the drug for.
There is
but
some trend that they may not do worse. So that's
yeah.
all we can tell.
Right,
Otherwise,
right.
we will expect for a grade 3 side effect.
Yes.
Thank you.
Thank you very much. So as a continuation to our drug session and in onconephrology, so in this panel we are going to discuss the most common drugs that we normally use and normally that we would kind of encounter in our OPD and this with, oncologists referring. So my panelists, one by one, they would come and discuss their drug for 10 minutes. And at the end of the session, we will have an open question and answer session as well as questions from the audience, so that at the end of it, we all grow wiser, at least about these 5 drugs. So we'll start with Dr. Urmila Anand, ma'am.
Good morning, and I must thank the organizers for between nephrologist and oncologist. And I have been given 10 minutes, so I will rush through it. And I will not mention any of the drugs. They are all nibs here. And whatever they are, you please, my slides are open. You can read these nibs and they keep on changing. So this is how I have been told to talk about the drug, indications, toxicity, treatment approach. Busy slide. Please kinases are enzymes. So we are actually dealing with certain enzymes which get inhibited, and the function of this kinase is to actually remove or phosphorylate a group of proteins. So, and the proteins are actually the transmembrane or non-cytoplasmic receptors. And they are the ones which we name them, EGFR, PDGFR and all those. So here we are dealing with the enzymes which get inhibited. And these proteins actually can be inhibited by monoclonal antibodies also. So when they are the monoclonal antibodies, then they become MABs. So this confusion should not happen, but there will be some time in between when we discuss some of those VEGF inhibitors, some MABs will come through. And they are actually divided into 2 groups, the receptor ones and the non-receptor ones. And to confuse the matter, there are dual specific tyrosine kinases. And there are almost 19 tyrosine kinases. That means these enzymes are part of our body. They are naturally with us, and these are the ones we are interfering with. So I must sort of congratulate the courage of oncologists to interfere with our physiology in so much. And they are interfering with enzymes which are involved in, as I will show you with a prototype, cell proliferation, migration, differentiation, survival. So if a time comes when all this 90 will be inhibited and we will not be left there. So, and they are also involved with certain diseases like immunodeficiency, inflammation, skin, atherosclerosis, diabetes, cancer. And the tyrosine kinases in cancer cells get activated either by mutations, translocations, and other problems. And when they get sort of modified and become abnormal, then it leads to tumorigenesis, metastasis, and other forms. But it's important to understand even wild type of the natural tyrosine kinases which we have in our body, if they get activated, can also be part of cancer pathway. So these are the ones. It started with many years back. These are the RTKs which are called FGFR, PDGFR, EGFR. These are the proteins where they get phosphorylated, dephosphorylated by the drugs called TKIs. Then you have the non-receptor kinases like JAK, ABL, the initial Philadelphia chromosome ones, and then you have the dual specific ones, the MEK. And these are all the ones I have mentioned there, and this is how it started. At the beginning of the century, the first drug that came to us, imatinib, and that is when we thought things will be easier. Now you look in the last 5 years, we have so many of them. Each one working with some drugs, some of these, all these substrates are given below, and these are the ones that we have. You don't have to please ask, and they will give you the slides. You don't have to take pictures, they will be given. And one of the prototypes that we use, and I'm personally involved because my mother-in-law in this for the last 7-8 years, is the EGFR TKI is commonly used in non-small cell lung cancer. There are reversible ones, there are irreversible ones. She started with the first generation geftinib. Now she is with the third generation osimertinib. And let me tell you, these drugs have made a difference. I'm quite old in medicine, and NSLC initially was something called, which was a cancer which no hope. Now we have an 80-year-old lady will celebrate her 90th birthday next year. So I know how these drugs have made a difference. This is a prototype. The EGF is the epidermal growth factor. The receptor is the protein which there is a phosphorylation moiety where the TKI inhibits with, and then it activates a chain of pathways in our body, the STATs, ERK, MEK, mTOR and all, which finally leads to some of the most important essential activities of a cell cycle: proliferation, apoptosis, angiogenesis, and invasion. So this is a prototype drug, and the indications in oncology are tremendous. I have divided them into the EGFR, HER2 TKIs, initially with non-small cell lung cancer. The HER2 ones are with breast cancer. Then you have the first ones, the NIBs, because of the BCR-ABL, the Philadelphia chromosome positive CMLs. They're also with gastrointestinal stromal cancers, CML. Then the next one is the PDGFR KIT group of TKIs, mostly with gastrointestinal stromal cancers. Then the VEGF ones, the VEGF TKIs are the common ones we use with a lot of renal toxicity like sunitinib, sorafenib. They are with renal cell, hepatocellular cancer, and other solid organ malignancies. Then we have the FGFR ones, which are with cholangiocarcinoma, bladder cancer. And then there is a whole lot of miscellaneous group with ALK TKIs, FLT TKIs, which are with various forms of cancers. Because as we mentioned initially, they interfere with 90 ubiquitous tyrosine kinase. The side effects are tremendous. There are various signs of toxicity. Look at everything can be inhibited and can cause problems. But we are with renal adverse events. This is a ChatGPT query, and you see what they have given. These are the ones which actually have come out: hypertension, proteinuria, interstitial nephritis, electrolyte abnormalities, TMA, and even renal artery stenosis. I was not aware of this. I looked into a paper, and it is soon to be involved. Hypertension is the commonest side effect. Happens within the first month, ranges between 40% to so with sunitinib, sorafenib, improves the vascular stiffness, can go up to almost 60% with the other ones, but the highest rate is with ibrutinib and lenvatinib, where almost 4 out of 5 patients can develop hypertension with these drugs. Proteinuria, commonly with the VEGF inhibition. We know about the monoclonal antibody bevacizumab, which is involved with vascular endothelial interference, but then they are also with the NIBs like sorafenib, sunitinib. And if they are biopsied, you can see all of these findings like collapsing GN, focal proliferative, cryoglomerular vasculitis, interstitial nephritis with sunitinib, and TMA. The anti-VEGF therapy has multiple reasons. This is the first paper in 2008 where it talked about the antibody, monoclonal antibody. But what is important to know, there is an ONCONEPHROLOGY course with American Society of Nephrology where they thought ki just not only bevacizumab, the molecule, but the TKI, like all those lists on the right side, sunitinib, sorafenib, regorafenib, and this side the VEGF-R2 antibodies like ramucirumab and aflibercept. All of them, because of their interaction with the endothelium, can lead to TMAs. This is with the BCR-ABL TKIs. They have been shown to interfere with tubular cell function, leading to renal failure, podocyte trophism, leading to proteinuria. Dasatinib is one drug. I have a patient admitted now with 8 grams of proteinuria. The drug, and the oncologists take it up, it comes to 2 grams, they restart it, again it becomes 8. So it keeps on continuing with this, and the next is the endothelial interaction with TMA and vascular cell. That's the last year with this very latest publication where they have also mentioned the higher risk of developing renal artery stenosis with a drug called nilotinib. The TMA, fluid retention, renal failure, all of it is significantly higher with this group of patients. Electrolyte disturbances also happen with not just with the monoclonals of EGFR, but also with TKIs affecting EGFR, leading to hypomagnesemia. BCR-ABL can cause phosphaturia, hypophosphatemia, and the BCR-ABL TKIs can cause PDGFR. The platelet-derived growth factor is a cell trophim, tubular cell trophic drug. I mean, whenever you have AKI or tubular cells injury happens, and when the recycling happens, these drugs inhibit and can lead to tubular dysfunction, leading to be aware of this. Some of these can be very important. And finally, this happened 2 days back, where they not only interfere with the real renal function, but actually damages the kidney function. And when I talked to my oncologist yesterday, he sent me a list of another 70 NIBs which can do this. So I have the WhatsApp message with me. So please understand, these drugs actually interfere because tyrosine kinases, especially the PDGFR tyrosine kinases, are ubiquitous in proximal and distal convoluted tubule. In the proximal convoluted tubule, they interfere with the OAT1 and OAT3, leading to interference with the creatinine excretion. So all that rise in creatinine may not be a real rise in creatinine. It is because of the tubular dysfunction. So management, these drugs, titration dose is not required. Oncologists will not let you stop the drug. So it is better to talk with them before and find out what they are using and discuss with them gently. Maybe you may use not this nib but the other nib, and so things may be done better. If you have a proteinuria, be very careful. Better to know what is causing the proteinuria before you start these drugs. And even if after you develop proteinuria, then you can manage conservatively depending on how much hypertension these patients have happened. So ladies and gentlemen and youngsters, all of you here, TKIs are increasingly used in oncology because of their superior selectivity, ease of administration. Most of them are oral. I think all of them are oral drugs and highly effective. But with their use, we are all looking at the toxicities. My mother-in-law has hypophosphatemia, but with discussion with oncologists on board, we can actually optimally select the drug and better utilize their efficacy. I thank Rajiv Lochana and all that to make you understand this. Nephrology is just not restricted to creatinine. And this paper in ACKD actually mentioned that all of you youngsters should think of not just interventional nephrology, but areas of nephrology and practice with, and you will make a lot of difference. Thank you very much for your kind attention.
The next talk, that is Dr. Jayalakshmi ma'am.
At the outset, I thank Triple M Hospital and Dr. Rajiv Lochana for this wonderful opportunity. And as Madam said, onconephrology is a field that's developing because we have a lot of drugs. And any drug means we'll have to think of renal issues because most of them get excreted by the kidneys. I'm going to talk about the vascular endothelial growth factor inhibitors, not only the MAPs but a lot of NIBs that Madam also mentioned previously. We are going to concentrate on the vascular VEGF signaling pathway inhibitors basically. So here, just a word about what is this vascular endothelial growth factor. Basically, every organ has got a blood supply, and right from embryogenesis, there is angiogenesis as well. And for this angiogenesis to occur, this VEGF plays the most crucial role. So whenever there is angiogenesis going to take place, we have the VEGF receptor, where we have the VEGF-A, and there are a few other VEGF also, which go and combine with the receptor, and they initiate a chain of events. The first one being, it can actually go through the protein kinase C pathway. We can see the mitogen activated protein kinase C, which actually results in increase in prostaglandin I2. Then we have the other pathway where the eNOS is activated. So all these things, basically, the idea is to increase the vascular permeability, vasorelaxation, and improve the blood supply to the organ so that the organ grows. So this is ubiquitous, and this is what is happening in the normal human being in all the organs. Both PGI2 and nitric oxide mediate many of the biological consequences, including enhanced vascular permeability, vasorelaxation, and endothelial survival. So it's very important for the survival of the endothelium. These may also antagonize the effects of vasoconstrictive mediators. So that's how they keep the blood flowing. So angiogenesis has been, it's an essential step in tumorigenesis as well. And in recent years, these have been targeted to reduce the cancer growth. On the other hand, we can see that this endothelial growth factor is very important for the kidneys, where the renal podocytes, they have to maintain a healthy endothelium, mesangium, and tubular structures. So this VEGF is very important. It has to be maintained properly to ensure a proper renal health. So with the disruption of these processes, what can happen is that there can be renal injury starting at the cellular level, and some people refer to as VEGF nephropathy. The syndrome is basically hypertension, thrombotic microangiopathy, proteinuria, and renal failure. So what does the VEGF pathway, signaling pathway inhibitors do? Actually, we have many of them. One which is actually targeting the VEGF, the monoclonal antibody, which is usually bevacizumab, which we have heard lots, and aflibercept. And we have one that targets a receptor, that is ramucirumab. Then we have the TKIs, which Madam talked about just now. And post-receptor, we have the MAPK signaling, mTOR signaling, and eNOS signaling. Many of the drugs target every one of these. So the aim of the drug that is given for malignancy is to reduce the VEGF activation. So there are so many drugs, as we saw. The MABs, the main thing is the bevacizumab, and the NIPS, and we have the everolimus, the Solimus, and ridaforolimus for the mTOR signaling, and we have the RAF inhibitors also. So what these do is, you just take, for example, a normal podocyte. There are VEGF. What happens? They go and bind to the receptors, and they maintain the growth of the endothelium. They maintain the health of the endothelium. Whenever there is going to be an antibody that's going to bind to the VEGF, then the receptors are not stimulated, and that results in endothelial injury. This is actually shown in two models. One is when we give a VEGF receptor monoclonal antibody, or when it's a knockout model. In both cases, you see that there is a lot of endothelial injury happening because this VEGF is not getting activated. So that is precisely what happens when a cancer patient is given all these drugs. So what all happens in the renal effect, you see that the anti-VEGF destroys the podocytes, and mainly the endothelial cells and the podocytes, and there is podocyte loss, actin cytoskeletal rearrangement, food process is effaced, and there is decrease in nephrin expression. All these things lead to proteinuria. And we have a TMA that's happening because basically the endothelial cell is targeted. We have the endothelial fenestrations are lost, microthrombi are produced, and there is reduction in local complement factor H synthesis as well, leading to a typical TMA. But this TMA differs from the regular TMA that we see in other places because this may be very much renal limited. We may not have all the manifestations of TMA, so we should have a high index of suspicion. Anybody coming with a proteinuria, with a hypertension, we'll have to be really careful. On the other side, you see that there is reduction in NO production, there is increase in ET1 production. What happens? Vasoconstriction takes place, and this results in hypertension. So you can see that there is also hypertension due to vascular rarefaction, and there is also increased peripheral vascular resistance. There is also decreased renal blood flow and GFR, and natriuresis is also decreased. So all these contribute to the hypertension that is seen in these patients. Basically, they say that the hypertension is seen almost in 25% of the patients, and almost all the patients who are treated with these agents have an increase in blood pressure. May not be in the hypertension range, but they always have an increase in blood pressure. Telling this just says that all the vascular endothelium actually are getting stimulated by this. Then, as we said, there is going to be proteinuria because of the various things like can be minimal change disease, can be an FSGS. So what do we do when we see a proteinuria? So what we do before starting anti-VEGF agents, we get a history and see if the patient has got already any proteinuria, any abnormality in renal function. So everything is normal, there is no proteinuria. You can repeat and see if there is no proteinuria, then probably you can start the agent. But then if there is any abnormality, measure all the renal function and see whether you're missing any renal issue, and then be sure that there is no renal issue before the patient is started on any VEGF agents. Once we start the anti-VEGF agent, we have to do dipstick analysis and quantitative protein test first before the cycle or every other infusion. If it is negative, we can boldly continue. But if it is going to be positive, check the blood pressure, keep the blood pressure at the correct level, less than 130/80. By giving, basically we can give calcium channel blockers as well as ACEs and ARBs. And then if still the blood pressure control is not good, we may have to think about it. You can actually give 2 drugs and maintain the blood pressure. But in spite of blood pressure control, if there is proteinuria, then we will have to see how much is the proteinuria. If it is with microscopic hematuria, or if the proteinuria is quite significant, we may have to go ahead with a renal biopsy. Because basically, we may not be just dealing with the VEGF side effect, VEGF inhibitor side effect. We may be dealing with something like a paraneoplastic syndrome due to the malignancy. The patient might be having a membranous nephropathy. So this is very important. And sometimes thrombotic microangiopathy presents only with proteinuria and hypertension to begin with. So we may miss that also. So it's very important to do a renal biopsy. But the problem here is the patient might bleed. So it's better to do a transjugular biopsy, which is safer than the conventional renal biopsy. So how do we manage? If the patient gets proteinuria, we will have to interrupt the treatment if the proteinuria is more than 2 and up to 3.5 grams per day. That is a subnephrotic range. But then, if the proteinuria is in the nephrotic syndrome range, we will have to stop the treatment. Basically, when we interrupt the treatment, we reassess, do the biopsy, and get back to the original dose, original drug, if possible. If the nephrotic syndrome is there, it depends on what the biopsy tells us, and then we may have to get back to the drug if possible. Otherwise, we'll have to consider alternate agents. With hypertension, we treat with CCBs and ACs or ARBs. One thing we must always remember is that we should always take the checklist of all the drugs the patient is taking, because there can be other oncology drugs which can cause hypertension. There may be other drugs the patient that's taking which may cause hypertension. So look at the drugs, any other drug which may potentiate the hypertension. Then if it is TMA, drug withdrawal has to be done, and there is no role for plasmapheresis in these cases. Thank you.
Thank you. Good morning, everyone. After 2 talks with relatively newer drugs, the NIBs and MABs, we'll go to something that's much more familiar for nephrologists, and it has been the mainstay of oncology treatment for a very long time. So cisplatin has been one of the most commonly used chemotherapeutic agents. It was approved for use in 1978 and has been commonly used in testicular, ovarian, bladder, and urothelial cancers, to name a few. But its use has been limited significantly by nephrotoxicity. So how does it work? Once the cisplatin moiety enters the cell through these transporters, which is the organic cation transporter 2 and copper transporter 1. Once it enters the cell, the chloride ions on the molecular structure are replaced by water molecules inside the cell, and that aquated molecule then is very electrophilic and binds with nitrates on protein as well as the DNA and RNA nitrates, and that adducted DNA then initiates a process within the nucleus which ultimately results in cell death. It activates several cellular processes, including the mediation of the arrest of the cell cycle, as well as inhibition of ATP and NAD. So the incidence of cisplatin nephrotoxicity varies according to the series, but it ranges between 20 to 30%. And in most of the studies, the AKI is non-oliguric. Most of the studies also show that you have largely more than 50% of stage 1 AKI by the KDIGO criteria. But as we've seen today, the problem with this is that the GFR measurement, what Dr. Priyamvada spoke about in the morning, the GFR measurement itself is suspect in many of these cases. And the rise in creatinine usually happens 3 to 10 days post-drug administration. So following GFR alone for making a diagnosis of AKI, well, creatinine alone for making a diagnosis of AKI usually does not work. There have been some studies which show that KIM1 levels tend to go up a full 48 hours before the creatinine goes up. The nephrotoxicity is usually dose dependent, but there have been reports of AKI even after a single dose, and can occur at doses greater than 60 milligrams per meter squared per cycle, or cumulative doses more than 300 milligrams per meter squared. Primarily, the effect of the nephrotoxicity is on the S3 segment of the proximal tubule, but it also, you can see effects along the loop of Henle as well as the ascending limb of the loop of Henle. So there are multiple mechanisms for how cisplatin causes nephrotoxicity. One of the most likely mechanisms is the accumulation within the renal tubular epithelial cell. Like we said before, their entry into the cell is via the transporters. And there have been studies which have shown polymorphisms of those transporters. And there is an overexpression of the transporter in the proximal tubule of some people. So there's a genetic variation for that. There are some drugs which interfere and cause overexpression, so that is one mechanism. There is also a process of oxidative stress which cisplatin causes by glutathione depletion, mitochondrial dysfunction, as well as activation of the endoreticular CYP450 system, all of which results in an increasing level of reactive oxygen species. And also there are the increased reactive oxygen species triggers pre-53, which results in a cascade of cytokines which result in apoptosis. There is also some reports of injury because of ischemia and ATN, which results in loss of GFR. And histopathology is rarely used to make a diagnosis of AKI in cisplatin nephrotoxicity, but when it is done, it shows degenerative tubular injury, cytoplasmic vascularization, tubular dilatation, and pycnotic nuclei with hydropic changes. The recovery after cessation of drug is usually over 1 to 4 weeks, and on histopath you will only see a partial tubular regeneration. In addition, there are also electrolyte abnormalities. Hypomagnesemia is seen, according to some series, between 40 to 90%. While some of this is GI induced, the vast majority is due to decreased reabsorption at the proximal tubule. Hypomagnesemia, once it occurs, is usually persistent even after the drug is stopped and is difficult to treat, and also increases the severity of the AKI that the cisplatin has induced. In addition, we can also see hypokalemia, which is worsened by the hypomagnesemia that these patients have. And the hypocalcemia and hypophosphatemia is again a result of the hypomagnesemia interfering with parathyroid hormone, decreasing its production as well as release. You can also see renal salt wasting and SIADH, which can happen secondary to the cancer itself, but both of those can result in hyponatremia. And there have been reports that say that cisplatin causes distal RTA as well as a Fanconi type of RTA, as well as some case reports of thrombotic microangiopathy. Most of the changes that we see in AKI are transient, but like I said, the hypomagnesemia can persist even after cessation of the drug. And the data for long-term effects of cisplatin are lacking. There was one study which looked at about 850 patients who had survived 5 years post-cisplatin exposure. And while there was a significant but small decline in GFR, the overall numbers of patients who have ended up with a GFR of less than 30 was only 3%, and none of them ended up with dialysis-dependent ESRD. So how do we prevent it? So mainstay of prevention for cisplatin AKI is hydration. IV hydration, 2 to 4 liters slowly over 4 to 6 hours during each cycle has been the mainstay. Magnesium supplementation, I said, it helps because it helps decrease the severity of AKI. 8 to 6 milliequivalents is what's been used. There have been some studies which looked at mannitol, especially when the cumulative dose is more than 100 per meter squared. But the randomized control trials with the use of mannitol and phosphoalkaline diuresis has not been the most convincing. There have been some multiple reports which have looked at interfering with the mechanism of action, use of magnesium, cimetidine, cimetidine, carvedilol, and pantoprazole. But these are all still case reports and not very inspiring in terms of efficacy. Once the AKI sets in, the treatment is symptomatic and looks at maintaining hydration and correcting the electrolyte abnormalities. This is a paper which came out last week. Published in the US. They did 2 parts. They used a large series of patients, about 12,000 odd, to first derive these 9 risk factors, which were then independently validated across 5 other centers in another 18,000 patients. And you've got these 9 potential risk factors where you can put in the scores and calculate a potential risk for AKI with cisplatin. The advantage of the study was that it was a very large sample, multicentric, and they've included severe AKI, which is usually not included in studies that looked at cisplatin AKI. And because most of these patients received cisplatin in the current era, 2006 onwards, it kind of reflects the current practice. And it has been externally validated. The big limitation is that most of these patients are in the US. All the centers were in the US, so how much you can extrapolate that data to our practice is not really known. So anyway, all of the above problems with cisplatin necessitated the development of less toxic varieties of the drug. So second generation carboplatin is the next best thing. It is better tolerated than cisplatin, and it works in pretty much the same way, but you need a 10-fold higher drug concentration and a 7 times longer incubation time to get the same degree of conformational change in DNA. And it is less efficacious than cisplatin in certain tumors. Where it works best in a similar manner is with the non-small cell carcinomas or extensive small cell carcinoma lungs. It is primarily excreted via the kidney, and there is no tubular secretion compared to cisplatin, and therefore the kidney clearance is proportional to the GFR. What that allows us to do is it allows us to calculate an optimal area under the curve, which is tailored to the GFR, and that is via the Calvert formula, where if you have a target area under curve of, let's say, 5 and your GFR is 100, you come up with a carboplatin dose of 525. So this is dictated by the pre-treatment GFR that you can use, and the side effect profile of carboplatin is similar to cisplatin, but it is considerably lower. There is a third generation oxaliplatin as well, which is most commonly used. It's used in colorectal cancer and a lot of other cancers. The side effect profile is even better compared to cisplatin and carboplatin, and you see a small levels of non-oliguric AKI as well as TMA and hypovolemia. I think that will be, that's where I'd stop. I would request everybody to scan this QR code. It'll keep coming up. There's links to a survey, and we'd request you to answer that survey.
And the last talk for this panel is Dr. Anita, ma'am.
My topic is on methotrexate. As we all know, methotrexate still forms a part of chemotherapeutic armamentarium in malignant diseases because it is the oldest drug, like the oldest nephrologist standing here. It has been included in the World Health Organization's list of essential medication, saying that it has stood the test of time. So it is definitely a useful chemotherapeutic agent, I suppose. And it's an anti-metabolite. It inhibits the synthesis of DNA, purine synthesis, and it is an anti-inflammatory drug, and so it has got a wide variation of usage in low dose, in high dose, in low dose by the dermatologist, rheumatologist, and even gynecologist for trophoblastic tumors. Recently, when I went across the literature, I see people using it for ectopic pregnancies also. So as far as the pregnancy is concerned, this drug belongs to the category D. I don't know whether they have updated it. And then the route of administration of the drug, it starts from oral, IV, intramuscular, intrathecal, and intravenous. And the dosage, again from low dose to high dose, oral dose to around 12 milligrams per meter squared, to around 20 milligrams per meter squared intramuscularly, and weekly maintenance dose of almost around 33,000 milligrams per meter squared in some acute lymphoblastic leukemia. You can see a wide variation of dosage used, and low dose around less than 25 milligram per meter square. High dose is usually defined in some papers as more than 500 milligrams per meter square, in a few papers to 1 gram per meter square. So how do you look at the renal toxicity of methotrexate? You classify them into a high-risk patients, and then you classify patients, what to do for such high-risk patients, and then you classify patients who have developed AKI due to methotrexate, which is very difficult to say because we don't routinely do kidney biopsies, and there are multiple factors which contribute, mainly hydration, other antibiotics which are used, and mostly methotrexate is used along with cisplatin, so you do not know which one to blame. AKI patients with malignancies, it's a very common occurrence. It has a negative impact across cancer patients, impacts chemotherapeutic regimens, so there is a longer length of stay and a longer period of remission rates is very long to achieve, and there is a high mortality. And there is difference in etiology and therapeutics and prevention between various tumors. Between solid tumors it is different, between hematological tumors it is different, so it is very difficult to say what happens where. But one thing we need to be careful. Coming on to AKI epidemiology population study, I stuck in with a small study from Denmark, in which we see the incidence of AKI in 1 year and 5 years, and the high risk of AKI among only 3 groups of patients which they have classified. Only is kidney cancer, liver cancer, and myeloma patients. They form the major chunk, so rest of them fall on the other category. Though it is a small study, I thought it's a good one to go across. So coming back to our drug, 90% is cleared by the kidney. So how does it happen? It gets precipitated in the tubules, enhanced by an acidic pH. So when there is an acidic pH, what you require is generally a small pH meter, so in which you can measure a pH, or you can use even your routine methods of estimating the pH. Very important in urinary pH is that you should estimate pH instantaneously rather than waiting for a long time, because the pH rapidly changes and it is a changing variable. You must alkalize the urine. When you alkalize the urine, what happens? There is 5 to 6 fold increase in methotrexate solubility. So when the methotrexate gets soluble, it is pushed out of the urine. AKI manifests usually as a non-oliguric one, and it's often associated with high serum drug levels in the serum and its metabolites. Not only that, because it is primarily eliminated by the kidney, the urinary metabolite is also high. But these are all papers which are done at the pharmacological level to assess the serum level, urinary metabolite and all. But the simple method is to alkalize the urine well. Risk of methotrexate levels rising leads on to severe, not only to renal injury, but also to bone marrow suppression and neurotoxicity. So the mode of action, as you all know, it's a quite an old slide. Only thing which I want you to concentrate is where does the leucovorin rescue act and where does the glucocarboxypeptidase acts, because one is acting inside the cell, the other is acting outside the cell. So when it is acting outside the cell, it will eliminate the serum level of methotrexate very fast, within say 90%, and it is excreted through the liver. Again, we must be careful because methotrexate is hepatotoxic also. The other one competes with the inside the cell to reduce the toxicity. But major toxicity of methotrexate is inside the cell, and then there is a slow reflex of methotrexate from the cell into the circulation, which is an important element to keep in mind because 50% of methotrexate is plasma bound. So that is not dialyzable. So once you dialyze, once you reach a serum level, you should not be happy. You should have a periodic follow-up and look in for a rebound rise of methotrexate. This is an example of a crystal nephropathy. There are, usually you divide interstitial nephritis into two categories. One is immunologically mediated. This one is non-immunologically mediated. So when something is non-immunologically mediated, you can reuse methotrexate at a lower dose so that you complete your chemotherapeutic regimen. So that includes the nephrology and the oncology consultation together. So acute and chronic nephrotoxicity results from precipitation and deposition of crystals of methotrexate within the renal tubular lumen. In addition, in rat models and monkey models, they have found out that it also reduces the blood flow through the afferent arteriole in the kidney. So this is not only the reason, there is also a glomerular element attached to it. The risk increases when the tubular urine flow is acidic. Therefore, volume depletion and hydration has to be taken care of. Risk also is increased when the GFR is less than 60 ml per minute in whatever way you estimate the eGFR. But normally, as what Priyambata said, the best way is to go for a modified EPI equation along with drug dosing. So indications of methotrexate: acute lymphoblastic leukemia, osteogenic sarcoma, non-Hodgkin's lymphoma, primary CNS lymphoma, trophoblastic tumors. These are the places we use very high dosages. So AKI prevalence is around 2 to 12% with high dose methotrexate initially. With supportive care, see how much it has come down to less than 4%. Therefore, supportive role plays a major role. So 9.1% of high dose methotrexate cycles in non-Hodgkin's lymphoma were complicated by acute kidney injury. Whereas in osteogenic sarcoma in children, the AKI was only 1.5%, but long-term follow-up of these children is the risk of chronic kidney disease is around 0.5%, which is very significant. These were the models which were used to identify the crystal formation in the renal tubules. So there are many protocols which are used. Protocols are only guidelines. They are not for individual patients. So you can modify your protocol, but the idea is to get enough hydration. Okay? And then periodic assessment of serum levels is a must in a person who has already developed methotrexate toxicity earlier. The exact guidelines for the serum levels are 50, 30, 10, 5 at intervals of 24, 42 and 48 respectively after high dose methotrexate dosage. So this is again very important that you should always keep in mind the drugs interfering with the elimination of methotrexate. This particular chart will tell you how many drugs are there which can interfere with methotrexate, and all the NIBs also reduce the clearance of methotrexate from the kidney. Supportive measures for hydration and urinary alkalization is given for an adult protocol here. So when the pH is more than 7, there is an 8-fold solubility of methotrexate. If the pH is around 6.5, what happens? If the pH is less than 6.5, how much you should give? And you measure the urinary pH regularly, at least for 48 hours. When there is an inadequate urinary alkalization, but patient develops metabolic alkalosis, they have also tried carbonic inhibitors in the dosage of 250 to 500 milligrams squarely. These are all small studies. And then how do you do a leucovorin rescue protocol? So how do you do this? There is a nomogram here. You can follow the nomogram. On one side there is a plasma methotrexate level. The other side is the time interval which has been used. This is how you use your leucovorin. So now you come on to the glucarpeptidase rescue. The cost is exorbitant. It is approved by FDA in 2012. Indications for patients who are in AKI, the plasma methotrexate levels more than 1 micromole per liter, 24 hours. Use supportive measures prior glucoperidase infusion. Most important, you avoid leucovorin rescue 2 hours prior and 2 hours after glucoperidase. And then you use a dosage of 50 international units per kg IV over 5 minutes. This is being, the methotrexate is converted into DAMPA and its metabolites, which are excreted predominantly through the hepatic system. But at the same time, you should remember 25% of patients with methotrexate have hepatic toxicity. So you must titrate the dose carefully. So now you come on to the dialysis in methotrexate toxicity. Peritoneal dialysis, what happens? It is largely inferior results because of protein binding. So anything which is protein bound is very difficult to dialyze. High degree of ionization. Here I should always tell you that prior starting methotrexate, you should be very careful that you don't have volume overload in any form in a patient, because it diffuses very easily into the pleural effusion, ascites and all that. If you have all those things, you should use it carefully. And as people mentioned, plasma protein is a very important marker. Albumin is a very important marker that you should stabilize the albumin and your nutrition first before you try them. And it has got a low lipid solubility. So for these reasons, peritoneal dialysis is quite inferior. Hemodialysis, though better than peritoneal dialysis, it is still inferior to high flux hemodialysis. Even in a high flux hemodialysis, you should make a point to see that there is no rebound increase in methotrexate, which is likely to happen after 48 hours. Whenever you are using dialysis as a modality of treatment to treat methotrexate toxicity, you should also use glucoperidase and leucovorin, but there are no individual studies to tell or crossover studies to tell you which is better. So leucovorin is dialysable, therefore you should give it post-dialysis. So rebound toxicity I have already mentioned to you. So this is an analog of methotrexate. It is used in non-small cell cancer and mesothelioma. It is often used with cisplatin. It causes ATN, nephrogenic diabetes insipidus and a distal RTA. Do not use it if the GFR is less than 45 ml per minute. Some patients with long cumulative dose may develop interstitial fibrosis and chronic kidney disease. And another important factor which is very important is diabetes is an independent mortality in patients when you use a methotrexate usage, because the pH in a diabetic patient is already very acidic. So you should know that. And many patients are on multiple drugs, so you should be again very careful. Again, patients who are obese, you should make adequate changes for methotrexate. Thank you.
Podium for questions from the audience if there are any. My first question is to Dr. Urmilanan and of course our oncology colleagues, that when we know that there is an incidence of pseudo-AKI in the TKIs, now where does that leave us? Should we just stop doing creats in these patients, or how do we analyze whether this is really an AKI or is it pseudo-AKI?
A renal injury in a cancer patient, especially post-treatment, could be multifactorial. So cancer as such can, all these TKIs are basically for the advanced stage cancer patients where they might be cachectic. So it's obviously a multifactorial cause which leads to renal damage, which also includes poor nutrition, lack of adequate fluid intake, and most of these patients would always have a high kind of protein metabolism, catabolism, and they might have a higher creatinine. So basically we look at correcting all these factors along with the possible factor that might be anticipated. That is number one. And number two, when we are using all these TKIs, we do not take a clinical decision on the first visit unless it is very grossly elevated. So if it is kind of correctable, we would ask them to review in about a 2 weeks time period, wherein patients do come back with repeat values. We'll see if there's any variation, if there's any improvement, if there's additional toxicity because of the drug that what we use. So everything put together over a period of time, say around 2 months to 3 months. When they are back for a response assessment, we would carefully look at the cancer prognosis, the outcomes, as well as possible side effects of the medication. So right at the first visit, it might be too early to decide on any of the additional problems that might need to be answered, but over a period of 2 to 3 months, we would evaluate the persons as a whole.
Right, thank you. Ma'am, Dr. Jayalakshmi, ma'am, you spoke about the VEGFRs. Now, we are also aware that apart from cancer, we also come across patients, diabetic patients with diabetic retinopathy and intraocular So at this point of time, is the management the same that we use or the doses being lesser? Do we have a different approach to that at that point of time?
Basically, nowadays, with the repeated intravitreal injections of the VEGF antagonists, we do see people with proteinuria. Basically, the amount of exposure to the VEGF inhibition is much less when compared to the VEGF inhibition that we give in cancer patients. So the disease is also a little less severe, but it depends on the severity of the manifestations. So we have to go by the proteinuria. Again, the hypertension has to be controlled well. And we have to tell them about the repeated hypertension, blood pressure measurements that has to be done, and escalating the dose of antihypertensives. Proteinuria is usually minimal, but then there is already diabetes in those patients. So we do have a diabetic nephropathy that might be underlying. So biopsy might be really helpful in these patients if there is significant proteinuria.
So this is probably a learning point for the nephro fellows here, that irrespective, so when these agents are used in oncology, the oncologist would check their proteinuria for sure, because it is something that is a part of their learning and their algorithms. But when you use this in ophthalmology, very rarely would an ophthalmologist have a baseline proteinuria, and the patient is going to come to you with proteinuria, and you will have to differentiate between this being a drug-induced, or the patient having an underlying diabetic nephropathy, or the patient coming with a new, maybe an NDRD in this case. So this is where you have to be really astute in your clinical judgment for this patient, and a biopsy would help here. Okay, the next question is again to I'm sorry, I'm asking more questions to the oncology colleagues here, but I think predominantly all of us being nephrologists here, we have a lot to learn from them. So
one
yes.
caveat on that, most
Yes.
of this Avastin and use is in dialysis patients actually.
Yes.
So some of them are anuric and also proteinuria assessment doesn't happen. What we see occasionally is a worsening of creatinine. So there are papers on that, and there is a paper just now by Keenard saying all three are equally good or bad. The aflibercept, ramucirumab, and all three. So
Yeah, worsening of creatinine as well as worsening of the hypertension.
that is more important.
Yeah.
No, so do you think carboplatin is traditionally considered to be a little less nephrotoxic as compared to cisplatin? Are these two drugs interchangeable? Would you prefer a carboplatin instead of a cisplatin, say in somebody who has a baseline GFR which is borderline, or they are not interchangeable drugs?
Yeah, we have evidence that they are not interchangeable, especially in germ cell tumor of malignancy. We are not supposed to use this carboplatin instead of cisplatin. It has a negative results. But in children, pediatric, where we can go up to 8 AUC, there are evidence that we can use carboplatin in children. But in adults, we cannot go up to that AUC. That is why it is not equivalent. So definitely it should not be replaced. And in this lung cancer also, it is not replaceable in a curative setting. But in a metastatic setting, definitely we will opt for carboplatin because the difference is less than 5% in survival or a progression-free survival. It is very, very negligible and it is quite safe. And we will be using this platinum for long time, second line, third line, like that. Suppose if you exhaust cisplatin in first line itself, so we have a limited option in the lateral lines. That is why we will reserve for resistant cases. But in curative lung, we will definitely don't replace cisplatin for with carboplatin.
So again, the learning point here is they are not interchangeable drugs. There are specific indications for both. So it would be prudent on your side to pick up the file and go and speak to your oncologist that is this something that we can do? Is this an option that we can do? Rather than just blindly writing down on paper that you just stop the cisplatin or stop the carboplatin. Remember, at the end of it, even the carboplatin is not renal safe. It's just relatively better than cisplatin. It has its own set of renal side effects that we have to deal with. Yes.
So basically, it's like how Dr. Shiva said. Cisplatin cannot be replaced with carboplatin in head and neck and gynecological cancers in a curative setting, especially when we are using along with radiation as a concurrent modality. So cisplatin, as a weekly dosage of 40 milligram per meter squared, would hardly cross 60 or 70 milligrams in a normal Indian man or woman. So when we are choosing that particular drug, there's obviously the associated side effects of the treatment with radiation, especially when patients would develop mucositis. Mucositis again boils down to decreased fluid intake. So we compensate that with an IV fluid hydration whenever the patient is admitted for cisplatin-based chemo. But when the creatinine rises, when a nephrologist is brought in or patient is an ICU, the first thing is written on the nephrology case sheet is, the consult is avoid cisplatin, which is obviously detrimental for a cancer patient when we avoid cisplatin. So in curative settings, definitely cisplatin is the choice of the drug, but obviously we'll have to consider the other factors as well.
Just a follow-up to that question, because this is what normally happens. So we come, we see the creatinine go up, and we are obviously, our hands are itching to say stop. Obviously, you can't stop. How comfortable are you with that creep in creatinine to continue the treatment?
So we would pause for a week, but continue with hydration. Sometimes oral hydration helps. Most of the times IV hydration definitely helps.
Yes.
So probably I don't understand the difference between consuming 4 liters of oral fluid versus 2 to 3 liters of IV fluids. It does make a difference. I really don't understand that.
The big difference is that when you give it IV, it's actually delivered. Oral is probably not delivered.
So again, the learning point for the fellows here is it's very easy to go and, I'm a nephrologist, I'm just going to go and say stop cisplatin. But you have to also, that is where the teamwork comes, that you have to realize that probably that is the only survival chance that that patient has. And maybe in such cases, you will have to sit down with the patient and make them realize that they might lose their kidney, but the risk versus benefit, they need to live. And the kidney is not priority over here. It's probably their life which is a priority. So you come somewhere in between rather than just going and writing that, avoid nephrotoxic drugs. It doesn't work like that. My other question, same for the cisplatin, is we face a problem with patients who are ESRD and they have their regular schedule of dialysis. So how do we kind of come to the dialysis schedule? Because cisplatin and the platins are basically drugs which are removed on dialysis, and they have a area under the curve and the dose concentration which is important. So there is a specific time limit within which after the injection of cisplatin where you will have to schedule your dialysis so that the oncologist gets a proper drug level. So would you want to tell us something about that?
I had a patient with carboplatin who are supposed to use carboplatin with the lung cancer.
Yes.
He's on dialysis. I think sir might be knowing. So there are both the evidence. If you are used before dialysis, we will use full dose, AUC 5 or 6.
Yes.
If you are using after dialysis, we will be using 1.5 like that, maximum 2. So I prefer this AUC 2. Even with that, at the end of the time, it did not turn up for the second cycle because of toxicity.
Okay. So essentially what you have to know is that if you're giving the full dose, you will have to dialyze that patient maximum within 8 to 10 hours of the initiation of the cisplatin on that day, because otherwise they will not be able to achieve their area under the curve, and then that dose has no meaning. So if you have a patient who has ESKD and is scheduled for a regular dialysis, you will have to go and discuss it with your oncologist, the timing and the dose of the platin, so that the patient gets an effective dose at the end of the day. Okay, ma'am, this question is for you. So you spoke about the alkalization. No, actually, ma'am, it's again for them, anyone. It's hell achieving that urine alkaline pH. The patient gets metabolic, means he gets metabolic alkalosis, but we don't achieve this.
Yes, it happens many a time. This is what is being described in the books. And I have not personally been near a patient doing all that, you know. I just started my ONCONEPHROLOGY probably a year or so, or 1.5 years ago, when I was along with the oncologist for some time.
So, yeah, ma'am, that's why I said they very practically do it, and how do they achieve that pH?
No, it is very difficult. You must ask the oncologist and not me.
What we do is, especially for the patients who are treated with osteogenic sarcoma,
yeah.
we start with 12 grams per meter squared.
Okay.
So 9 to 12 grams per meter squared is the recommended dosage for high-dose methotrexate in osteogenic sarcoma as well as in primary CNS lymphoma. So we start with a hydration with the addition of bicarbonate. We have a alkaline pH of the urine first with proper hydration, and then start on with methotrexate. And once the methotrexate levels are delivered, we have these patients monitored once in every 6 hours with serum methotrexate levels. And 24 hours after the methotrexate infusion is completed, we start in with the leucovorin rescue. The patients are admitted in the hospital till the methotrexate serum levels fall to the baseline. So it's going to be a long hospitalization for these patients with continuous monitoring of the serum methotrexate levels, alkalization of urine, diuresis with proper monitoring. And we generally do not recommend methotrexate whenever the patient has a third space fluid accumulation. Whenever there is a pleural effusion or ascites, we generally try to tap it. But again, it's sometimes more difficult between titrating between the clinical scenario, whether to give the dosage or not. So there is a dosage titration for particularly these patients.
But have you ever required the need for the acetazolamide to be added, because you are able to achieve the urine pH with just the IV bicarbs?
Yes.
Yes. And the same is the hypomagnesemia of cisplatin. Again, this is a prolonged effect and it's very difficult to treat. So what's your opinion about, or Sanjeev, what's your opinion about using SGLT2 inhibitors here?
New kid on the block, it's there everywhere in nephrology. I don't think there's much evidence right now to say, okay, it's very, very effective, but I don't see any harm in using it, especially as long as we are monitoring the renal function and the electrolytes. I have a fairly okay result with oral magnesium oxide, 400 milligrams BD, and then follow the magnesium levels. But I'm not sure if SGLT2 inhibitors is going to significantly alter that.
Because the problem with hypomagnesemia, it's very prolonged. I mean, even after you stop the cisplatin therapy, and they come back with those cramps and the associated this. So right now, the recommendation is that if you are not able to achieve with oral, where there have been observational studies where addition of SGLT2, and I'm seeing a lot of oncologists upfront adding them because it makes life easier for them. So that's what we are doing in Tata. So
I don't think we've seen any oncology prescriptions with SGLT2.
For patient, currently we have a girl with osteogenic sarcoma, who receives cisplatin. The magnesium is like 0.91 with mass and hypokalemia also. So obviously the mass are even more. The only question I have is would it worsen the hydration in these patients? But now we are getting, like, for example, cisplatin reduced especially.
Yeah, because SGLT2 do have a diuretic effect. Maybe it would be prudent to use it on the OPD basis after the patient is, stabilized and dehydration is not our issue? And in such cases, where you're giving magnesium and you're still having 0.8, 0.9.
After you've built your magnesium up to a certain level, fine, but at that level, patient has to be anyway inpatient.
No, this is additional therapy. It's been recommended as additional therapy, not as upfront. So maybe, on the OPD basis, because theoretically speaking, SGLT2 does cause diuresis, so they would get dehydrated and that would be an added headache for us. So
what happens to the potassium? Because, for example, in such a patient that is hypomagnesemia, corrected a little bit like 1.5, 1.6, and the potassium still remains 3. So the SGLT2 is going to bring down the potassium also. So I think probably we will have to continue the supplementation along with.
Thank you. So, any more questions from the audience?
Just one question now. So, ma'am was talking about desatinib. So, we have seen quite a bit of desatinib-induced proteinuria. In fact, we biopsied, I think, 2 days back. And actually, one of the patients was imagined, and he's been game changers in management of CML and things like that. So, she actually came with, they just switched over from imagined to desatinib. Within a week, she became flawedly proteinuria. But actually was steroid resistant nephrotic syndrome. So we used tacrolimus in this patient, and from the oncology standpoint, they switched back to imatinib. And currently she is in, I would say, a partial remission. Still not, and my colleague was saying desatinib also has a lot of PAH, and most of them end up stopping. So do you have any sort of
Actually, that was the question I am supposed to ask. Actually, I have a patient, elderly man. He presented with acute kidney injury with CKD, and subsequent evaluation he found to have chronic CML. First, he was seen by hematology. He started on imatinib. He again developed AKI and worsened. Then stopped. She gave hydroxyurea, 500 OD, but myelosuppression was very severe. Hemoglobin dropped to less than 6. Then I saw and started on dasatinib only half the dose. Even though we can give full dose 100 mg, there are evidence that 50 mg is equally effective as 100 mg. So I don't want to take a chance. I gave 50 mg. Again he developed fluid retention and worsened. So since we have limited option, I have just 25 mg. The patient himself started after taking that drug. Within 1 to 3 hours, he had a fluid retention, breathing difficulty. He just stopped by himself. Even 25 mg is not able to tolerate. Now I recently started on bosutinib since it has a very lowest chance of fluid retention. 200 mg is what recommended for a CKD patient. So I'm just waiting for his response. I am asked to review after 5 days. That was the question I am asking. I was supposed to ask Dr. Urmila. But
proteinuria. And then patient himself said, I developed proteinuria after dasatinib. I want to reduce the dose. I said, I am not the person to say, no, I can. Then he did some count, and then he went back and asked one of the oncologists and took a second oncology opinion, and then he reduced his dose. But they were all responding to steroids and modified Ponticidi. So he himself titrated his drug finally.
So I think that is an issue for all of us, whether this is drug-induced, whether it is paraneoplastic, whether it is a de novo glomerulonephritis, and how do we treat it? Because if it's paraneoplastic, you treat the malignancy. If it's de novo, you treat the GN. If it's drug-related, then either there'll be a change in dose or change in the protocol of the drug. So this, I don't think has any, I mean, the histopath is going to tell you that the patient has membranous, but then the questions will start after that, that is this paraneoplastic, is it drug-related or what? But so in the end, so you just started with the new drug and our prayers are with you. I hope he responds. But you have a whole armamentarium of nibs. You can just add on to something. Okay.
Ponatinib is worst drug. It is recommended for second line and third line only. We have only 4 drugs. That patient is uncontrolled diabetic also. So we cannot give nilotinib also. This is the third drug I am trying. We will hope for the best.
Yeah. Is that proteinuria or is it just fluid retention?
No, fluid retention, worsening of CKD. The creatinine is rising up and he is becoming very symptomatic. He is having chest dyspnea, breathlessness, and he comes to hospital, and with the diuretics he improved and discharged. Dasatinib, it is given it is the safest in the literature actually, in the CML, but worst drug I think in the practical.
So as I said, our prayers are with you. Do let us know what happened to that case. And if there are no more questions, I'm going to stop this session. And all I'm going to say is I'm very happy all of us took up nephrology. Just imagine remembering the name of 90 nibs and nabs. I don't know, I would have given up somewhere in between without the degree. So thank you so much. And
so coming to PTLD, this is one of the most important malignancies after solid organ transplantation as well as the hematopoietic stem cell transplant. And majority of PTLD cases are usually observed in the first post-transplant year. And the magnitude of cumulative immunosuppressive burden has a crucial role in PTLD evolution. So it can present like a localized lesion or as a systemic lesion. So one should be very vigilant in identifying this disorder. So lowering the clinical threshold of PTLD diagnosis is fundamental. So tissue diagnosis is crucial for PTLD diagnosis. That's why I am standing here. So you see that overall like post-transplant malignancies, PTLD comes almost like 21% of all the malignancies. So you can just divide them into two categories, like simply like B cell proliferation and T cell proliferation. So among both of them, B cell proliferation is the most common one. So T cell also we can get, and B cell is the one which are like influenced by the EBV, and the blunted immunological surveillance is the basic pathology underlying this B cell proliferation, and EBV positivity is commonly seen with the B cell proliferation. Usually T cell proliferation we won't see because EBV has the affiliation towards the B cells only. So the EBV positivity can be like a post-transplant viral reactivation, or it can be like a primary EBV infection through the donated organ or from the environmental exposure. So these days like we have like increased awareness of PTLD prevalence because better diagnostic technology and older age of donors and recipients and increased awareness of this disorder, the advent of new immunosuppressive strategies and introduction of the haploidentical the transplant and all. So this together like increase the awareness of PTLD. So coming to the risk factors, so there are something called like standardized incidence ratios. So it is like this is the like the lymphomas like among the transplant cohort divided by lymphomas among the normal population. So they formulated and we get that SIRs. So usually for the solid organ transplant, NHLs gets the 10 and Hodgkin lymphoma 4, and you have like 3.2% of all the PTLDs are this post-transplant. So the risk factor also depends on the type of a transplant, whether it's a solid organ transplant or allogenic stem cell transplant. Okay, so here in this graph you can just make out the relative risk, like you can see that it increase more for the intestinal one, the transplant, then slowly going down towards the kidney. So we can see that this is the relative risk for each organ transplant. So these figures suggest that the amount of lymphatic tissue in an allograft and the degree of immunosuppression are the key factors. Okay, so allogenic hematopoietic stem cell transplant, you can see that even this like haploidentical allogenic stem cell transplant, unrelated donors and umbilical cord and matched related donors, so each has a different risk ratio. So what are the things can increase the risk of PTLD? So EBV status, obviously the EBV seronegative recipient, especially with EBV seropositive donor, you have the high risk of getting this, and also like even the type of transplant, like as I already shown, like the intestinal and the multivisceral has this the highest risk, and then comparing to the kidney and the stem cell transplant. So type of immunosuppression, like if you are like treating aggressively with the T cell depleting agents, so it also like contributes to develop PTLD. And also the treatment for rejection and longer duration of immunosuppression all increases the risk. And predominantly it's a male, there is a male predominance. And also age-wise, if you see, the early onset of PTLD is seen in mostly in the childhood and old age, and the late onset PTLD is seen in the older age group. So the other, apart from history, physical examination and all, there are some of the investigation generally we do. We all aware of this, all the usual count, LDH and the urine analysis, EBV status of both recipient as well as the donor we need to do. And the EBV virus, like we can assess them in different ways, like the EBV quantitative, like EBV PCR, viral load. So all we can do. And also the radiological studies can be done to see the distribution. And also lumbar puncture can be done to see the CSF analysis, to see the any CNS involvement is there or not. Okay. So basically histopathology examination of the tumor can only determine the definitive diagnosis. So pathogenesis, if you see the impaired immune surveillance of tumor cells, that is the basic fundamental issue here. And the medications have some of the medication like azathioprine and all have a direct damaging effect in the cells. So they can also induce malignancy. So the oncogenic EBV plays a key pathogenic role. So impaired immune surveillance and DNA damage may play a bigger role in EBV seronegative patients. Okay, PTLDs after organ transplantation are generally host cell origin, unlike in stem cell transplant where the most of them are like donor cell origin. Okay, this is the pathology just to understand like what is happening here. So here you can see that EBV lytic program is happening, and then there is a TERT activation here. Then it goes into EBV latency program where together they stimulate B cells. So B cells stimulation, and also it also activates the immune, here some of these interleukins and all those things that in fact again activate the EBV. So here there is a B cell stimulation, then you have the expansion of EBV infected B cells. So they again like involving all the circulating mRNA and circulating TERT, and finally they leads to the onset of EBV related PTLD and the outcome of disease. Okay, again here also we can see that the life cycle of EBV virus and how it related to PTLD, like where you can see the mucosal epithelium entering, EBV is entering here, and you can see the B cells getting affected and infected naive B cells, and they again like they become this latency that program and memory B cells, then they get into the inside, and you see this EBV infected plasma cell and viral replication that is and all is happening. Okay, so finally they stimulate the B cells and there is a B cell proliferation. So we can see that according to the PTLD sites, we can see the lymph nodes are the most common and followed by GI tract. Among the extranodal, GI tract is the most common site for PTLD. Okay, so here we can just see that difference between the EBV positive PTLD and the EBV negative PTLD. So we can see that the molecular genomics are quite more involved in the EBV negative PTLD, because in the EBV positive, EBV takes over the full control. So you have fewer genomic abnormalities, and the origin mostly B cell proliferative here, EBV positive. EBV negative, mostly they are T cell. And also you can see the germinal center, like the cell of origin if you take, it's most of them are like non-germinal center B cells. And here in the EBV negative, they are mostly germinal center B cells. So more common in the first peak, and it is less common and usually seen in the second peak, and less risk compared to the seronegative transplant recipients. Okay, so yeah. So clinical manifestation, if you see the PTLD, it can, as I already mentioned, it can present like a localized disease or a disseminated disease. So tumors are often aggressive, they are rapidly progressive and potentially life-threatening. And the clinical symptoms can be like a patient can present with a fever most commonly, then lymphadenopathy, and GI symptoms can be there, and infectious mononucleosis like syndrome, and pulmonary signs and CNS symptoms, weight loss, all can be there. So you can see that percentage-wise, fever is the most common one, and you can have all this. And when to suspect PLD? When you see the declined allograft tissue function, and this organ failure may be the presenting symptom, and having high index of suspicion clinical vigilance is very critical. So we need to be very aware, and we should correctly catch the patient at this point. And symptoms can be non-specific sometimes, and systemic signs like hepatosplenomegaly, fever, fatigue, and all can be there. And raising blood level of EB viral load in this clinical setting should also raise the concern of PTLD. So localization, it can be nodal or extranodal. So among the extranodal, GA is the most common site, and others can like liver, lung, CNS and other. In the allograft itself you can get. And more than 20% of liver and more than 70% of intestinal transplant PTLDs occur in the allograft. So less common sites like the oral cavities, skin and subcutaneous lesions can occur, and T-cell lymphoproliferative disorders not associated with EBV infection tend to occur at extranodal sites. Okay, so you can, so coming to the classification, this is according to the recent WHO classification, 5th edition. So they classified them into non-destructive PTLD and polymorphic PTLD, monomorphic PTLD, classic Hodgkin lymphoma, then mucocutaneous ulcer. This is the latest classification. So among the non-destructive, you have like just non-destructive means they won't destroy the architecture and all. There is just exaggeration of a usual reactive process. So you can have a plasmacytic hyperplasia, you can have an infectious mononucleosis-like appearance, and you can have a florid follicular hyperplasia. Okay, so generally it occurs usually in the onset after the early onset after transplantation. So mass lesions in the tonsil, adenoids, lymph nodes, GA involvement is adenoids will be there. GA involvement is rare in this. And architecture usually they are intact, or it may be like a distorted. It is not effaced; it is just a distorted. It means just a paracortical expansion, follicular hyperplasia, those kind of features you will see. Most of the lymphocytes are not clonal, they are all polyclonal. Okay, so they are not really neoplastic, but they are polyclonal proliferation of B cells. So EBV positivity almost always is there. Okay, so next is polymorphic PTLD. So we just saw non-destructive, means the just non-destructive PTLD where you have all this hyperplasia and all, and next you have the polymorphic PTLD. It is little bit one step above that. Like here also you see mostly polyclonal B cells, but you may get some clonal B cells also in between, but that doesn't mean that it is a lymphoma. So we have to be very careful in making the distinction between the lymphoma and this proliferation. Okay, admixed T cells will be there. This is the picture just to show you. And if somebody is like very new in pathology, like if I just show that, they may say that it looks like a lymphoma because there are large cells and some prominent nucleoli are there, and many cells are looking a bit irregular, and some of the mitotic figures are there. So they may think that, but actually seeing that this is the just reactive proliferation. Actually, they are immunoblastic like cells proliferation. If we do the immunohistochemistry markers, we can distinguish between this proliferation and a Hodgkin lymphoma. They are all like they are not RS cells, they are RS-like cells. Okay, and as reporting usually this is that WHO has given us like this is the format we need to use. Okay, for this we can say EBV positive post-transplant lymphoproliferative disorder favor polymorphic type. Okay, this is the report. So again the polymorphic PTLD, this is what I already covered that. Yeah, coming to the monomorphic PTLD. So monomorphic, the term itself indicates that it is clonal, basically, monomorphic, clonal. So they can be B lineage, they can be T cell lineage or NK cell, or it can be plasma cell neoplasms as well. So among the B lineage, we have mostly diffuse large B cell lymphoma, Burkitt lymphoma, and marginal zone lymphoma. Actually, if you notice here, the WHO clearly says that the small means the low-grade B non-Hodgkin lymphomas will not be considered as PTLD. Okay, except the EBV positive marginal zone lymphoma. Okay, that is the only one point we have to notice here, because they are all like not considered as PTLD. Usually they won't develop post-transplant, you won't get any low-grade lymphomas generally. So marginal is the exception where you can have a EBV positivity. In a normal population, marginal zone lymphoma will not have a EBV positivity, but here you will have. And this is just one case, so without showing some of the microscopic pictures, I will not be able to sleep. Okay, that's why I just added this case, just to have one glimpse. So this is a 22-year-old male, so post-renal transplant. 2016 transplant was done, so the patient presented in 2023. So he presented with a mesenteric lymphadenopathy, so ultrasound guided biopsy was done, and you can see that all the cores completely effaced architecture, and you can see that lot of large cells like vesicular nucleus and nucleoli is prominent, and lot of mitotic and apoptotic activity. So basically this is a high-grade lymphoma. So after doing the markers, I'm not showing all the markers. So CD20 is positive. It means it is a high grade B in non-Hodgkin lymphoma. So MIBON is like more than 90%, and CD10 is positive. CD10 is the germinal center marker. So basically the final diagnosis is diffuse large B-cell lymphoma, germinal center type. Okay, so the sample report will be like this. So lymph node, mesenteric, ultrasound guided biopsy. So diffuse large B-cell lymphoma, GCB type, germinal center B-cell type, and post-transplant lymphoproliferative disorder, EBV negative. So we have to tell what is the entity, and we have to tell that setting, what setting it is, like post-transplant or whether any other immunodeficiency. So for all the immunodeficiency related lymphomas should be reported in this format. So what is the setting? This is a post-transplant PTLD setting, and EBV status finally we have to give, whether EBV was positive or negative. So this is the format we have to give. So in this case EBV was negative. Okay. So yeah, so I already this table summarizes whatever we have seen so far, and where you will have this obliteration of the architecture will be there, and you have all the lymph nodes, GI, liver, bone marrow, everything involvement will be there. Yeah, so next is the classic Hodgkin lymphoma. So classic Hodgkin lymphoma, it is almost like similar like what we normal population we see. That is the same thing here also we see. So under PTLD, so the classic Hodgkin lymphoma as such, it has 4 subtypes: nodular sclerosis, mixed cellularity, lymphocyte rich, and lymphocyte depleted. So among that, mixed cellularity is the most common in India for the normal population. The same thing for PTLD also. So mixed cellularity is the most common subtype seen here. So usually, even though they are known as, the RS cells are known as B cell origin, but their functionality will be reduced. So CD20 generally it is like either negative or very weakly staining. So case 2 is a 48 male post renal transplant 2008. Again the patient presented in 2023, and retroperitoneal lymph node and ultrasound guided biopsy was done. Okay, so here you can see that there is a polymorphic lymphoid infiltrate with the large cells, scattered large cells you can see. Other high power you can make out this kind of binucleated cells and all. And some of them are like lacunar cells with the lacunae around those large cells. And yeah, so when we did the markers, CD15 is nicely positive in those large cells. CD30 is also nicely positive in those large cells. And PAX5 is a B cell marker. You can make out this is a normal B cell which is darkly staining. This is the RS cells which are weakly staining. So it means that they are crippled B cells. So that confirms it is a Hodgkin lymphoma, and EBV LMP1 is positive in those large cells. So LCA is negative. So the final diagnosis is lymph node retroperitoneum ultrasound guided biopsy, classic Hodgkin lymphoma, PTLD setting, and EBV positive. So that's how we have published this case actually. So yeah, last one is the mucocutaneous ulcer. So basically here in the mucocutaneous ulcer, this is a new entity. In the earlier classification it was included in WHO, and BBB positive mucocutaneous ulcer, even though it may look like a lymphoma, but basically it is because of the immunosuppression, this lesion develops. Once you stop the immunosuppressive agent, it will automatically resolve by itself. So you don't need to really have any chemotherapy agent to treat this condition. That is the significance. Okay, so again you can see that EBV positivity in the non-destructive and the polymorphic, we have like highest level of EBV positivity. Going to the monomorphic, it total coming down a little bit. Okay, so the early lesions and these non-destructive and the polymorphic lesions have almost all the time they will have a EBV positivity. Okay, so there is a difference between early PTLD and the late onset PTLD. Okay, in the adults as well as in children. So in the adults, if you see the EBV positivity is in the early PTLD, you will see EBV positivity, and here mostly they are EBV negative tumors. So graft involvement can be seen in early, and less often graft involvement is seen in the late onset PTLD. And you can see that here the monomorphic, less often we see monomorphic subtype, mostly they are non-destructive, and the polymorphic subtype. Okay, so risk factors are all same. In the pediatric population, the DLBCL usually present in the early PTLD, and the late PTLD you see Burkitt lymphoma and Hodgkin lymphoma, they are mostly late events. Okay, So that is the one point we have to notice. And here it is like the time to PTLD is like shortest for heart, lung transplant recipients, and early PTLD is quite frequent in liver transplant recipients. And here the longest for the heart transplant, and the risk for late PTLD event is more than 10 years after transplantation. So differential diagnosis is usually the presentation may look like some infective, like some opportunistic infection or some kind of viral or bacterial infection. So we have to clearly monitor and see and pick up this PTLD. And the graft rejection also can confuse with whether the patient is having a PTLD or not. Whenever we encounter these clinical scenarios, we have to keep that PTLD also one of the differential diagnoses. So treatment and management is like all the strategies are different from the management of lymphoproliferative disorder in the immunocompetent patients. And here the mainstay of the management strategy is like the reduction of immunosuppression, then rituximab therapy, and all other like added like according to the clinical scenario you can add to the other therapies. So prognosis generally with the introduction of rituximab and lymphoma specific treatment regimen, overall prognosis of the patient with PTLD has improved quite a lot. And also the International Prognostic Index is the commonly used prognostic index derived from 5 variables: age, stage, LDH level, and performance status, and the number of extranodal sites, and all this. With that we can assess the prognostic index. And the retransplantation after treatment of PTLD is possible, but it is advised to wait at least 1 year after treatment of PTLD. So prophylaxis, what we can do. So EBV zero status of both donor and recipient should be recognized before donor selection, and the fine tuning of the immunosuppressive burden to as low as clinically possible. And also the preemptive or prophylactic antiviral therapy in potentially high risk groups should also be considered. And also the maintenance of high titers of anti-EBV antibodies by giving IVIG or you can administration that cytogam administration is recommended. And the preemptive therapy should be considered in select groups that are at a high risk of developing PTLD. Furthermore, monitoring the EBV viral load in a high risk case and considering preemptive reduction of immunosuppression with raising titers and close monitoring of allograft function has also been recommended. Okay, so this is just unpublished data from our institute. So study period is like last 10 years we just took, and a total of 19 PTLD cases we got, and among them most of them are like post-renal transplant, like 14 cases, and 5 cases are post-bone marrow transplant. And age-wise, age distribution, the eldest one is 67 years and youngest is the 12 years. And quite strikingly male predominant, 15 cases are male and 4 cases are female. And yeah, you can, among the diagnosis wise, DLBCL was the most common one. And yeah, otherwise you have like classic Hodgkin lymphoma and other T-cell lymphomas also is there. Okay, this is just in our published paper. This is that algorithm is given. I think it will be quite useful, I thought. It's like post-transplantation, you need to just see the red flags which increases the risk of PTLD. EBV positivity status, both donor, means donor positivity and recipient negative, and persistent of high degree of immunosuppression, and first year post transplant pediatric age group, all are like increased risk categories. And when to suspect PTLD, like you have like clinically you have constitutional symptoms and lymphadenopathy, any organ specific symptoms, and imaging also you can make out. And how to diagnose this? It is definitely by the tissue diagnosis. It has to be diagnosed along with you can PET scan and all. You can just see the staging can be done with the. So management, like you know that reduction of immunosuppression and all other agents you can use. So for the refractory PTLD, salvage chemotherapy, autologous stem cell transplantation can be considered. So concluding, PTLD is caused by immunosuppression and decreased T-cell immune surveillance in transplant recipients. The incident varies with the type of allograft, whether it's a solid organ or is a stem cell transplant, and degree of immunosuppression and EBV zero status of the recipient are important risk factors for PTLD. So PTLD varies from benign proliferations to monomorphic malignant lymphomas. And PTLD should be suspected when patient present with this kind of unexplained constitutional symptoms and other signs you can see. And diagnosis classification require pathological confirmation, and better understanding of the pathophysiology and the improvements in immunosuppression and advances in diagnosis and treatment have led improved clinical outcomes and overall prognosis. Any idea who is this person? Any guess? Something about we spoke so much in the PTLD. Yeah, he is Dr. Epstein. Yeah, just actually a few days back, I think 3-4 days back, he passed away. And along with Johan Barr, they only uncovered the EBV in 1964. So just I thought to give a tribute to him. Yeah, these are my references. Thank you.
Thank you, sir, for the wonderful session.
So good afternoon, everybody. I'm really impressed coming to this place and looking at the interest that people have in onconephrology. At the outset, I'd like to thank the organizers, especially Dr. Rajiv Lochan and Sanjeev for having me here. And I have a disclaimer before I start, is that the previous speaker has taken most of the slides from my desktop, so that's a big problem. Now I don't know what to speak about, sir. So anyway, what I'm going to do is I'm going to cut short most of my slides, and we have a common discussion in the end. So today I'm going to be talking to you about a nephrologist's perspective of PTLD, and from the previous slides you already know that PTLD is primarily because a lot of kidney transplants taking place. We have most of the data related to kidney-related PTLD transplantation. Okay, so I'll start with this index case. I'm not going to be running a lot of pathological slides because, again, he stole all my slides. Okay, so this is a 52-year-old male. He's diabetic, hypertensive, hypothyroid. He's undergone transplantation about 7 years back. His basic disease is diabetic kidney disease. He's undergone an ABO-compatible transplant. Donor was his cousin brother. And he's received a 2.5 milligram per kg. That's the standard protocol. We have 1.5 to 2.5 milligram per kg that we use in most of our patients in our center. He's on triple drug immunosuppression. He has very stable graft function here now, but he presents to the hospital now with complaints of anorexia, nausea, and pain in the abdomen. And so this is 20 days duration. So when you look at such a patient, then you go through the differential diagnosis as has been spoken before, and we try to think that probably we're dealing with something which is like an infection, anorexia, nausea, pain, abdomen. And when we look at his examination, he's mild tachycardic, his blood pressure is on the lower side, but his systemic examination is essentially normal, as well as his other examination is within normal limits. So when you investigate this patient, you find he has a hemoglobin on the lower side, and his graft function surprisingly is normal, 0.8, and on his LFT everything is okay except that you see a raised LDH. His protein creatinine ratio is within normal limits. When you do his ultrasound of the whole abdomen, you find that the graft kidney is normal and there is some inflammatory thickening of the bowel. So that excites you, and you do a CT scan of the abdomen and you find enlarged mesenteric, retroperitoneal and right iliac lymph nodes. So that's where you think that you probably are going to get something from these lymph nodes. So you do a diagnostic laparoscopy and you do a lymph node biopsy, and this is what you find in the excisional biopsy, and I don't think anybody would be surprised on looking at all of this, that this is a diffuse large B-cell lymphoma, and this is compatible with monomorphic PTLD. So he started on a regimen, and then after that he's followed up. Later on, presently the patient is undergoing treatment. So to start my presentation, ladies and gentlemen, post-transplant lymphoproliferative disorder is actually one of the most feared complications following kidney transplantation. And over a 10-year period, the risk of PTLD in our subset of patients is 12-fold higher than in a matched cohort of non-transplanted patients. The risk of developing PTLD has been increased with times as we have had new immunosuppression coming our way, and the lifetime risk is definitely higher in pediatric kidney transplants as compared to adult kidney transplants. This is a slide that was again stolen from my laptop by Dr. Saab, so I'm not going to be really discussing this, but I understand here you see that the incidence is lowest in the kidney, but everything that is presented is on the kidney because of the number of patients that we have with kidney transplant. And also, there's one more interesting thing is that the graft is the least affected when you're having a patient who has a kidney transplant who comes to you with a post-transplant proliferative disorder. Coming back to the burden of PTLD, we have some studies from our country. This study is from the Postgraduate Institute, Chandigarh, in which they analyzed about 2,000 kidney transplant patients, and they found that just about 1.45% of the patients had PTLD, which accounted for about a very large number, which is about 72% of all malignancies after transplant in their cohort of patients. But what's important here is that they had a decent amount of patients who had no EBV, so that means most of these patients were diagnosed quite late, and that was what was talked about in the previous talk, that late onset ones have EBV negative preponderance. This data comes from the All India Institute of Medical Science from the Pediatric Nephrology Department, where they found 4 cases of PTLD among about 95 pediatric renal allograft recipients over a period of 21 years. And immunostaining suggested B-cell origin in all the patients. There was only one patient who had Epstein-Barr virus, and all patients were successfully managed with reduction of immunosuppression or either rituximab or either excision of the affected tissue. So over a follow-up, there were no episodes of disease recurrence or allograft rejection, and the renal function was surprisingly preserved for all. We tried to dig up some data from our institute. This is still unpublished. There's an analysis of about 3,200 kidney transplant recipients, and we found that just about 0.5% of our patients, which accounted for about only 18% of all malignancies in our cohort of patients. And as would not be surprising, most of the patients had the B-cell related disorders, that is the diffuse large B-cell lymphoma. All of these patients were males, and we used a lot of thymoglobulin and grapholon in our patients. So thymoglobulin was given in 3 patients, grapholon in 1 patient, EBV positivity only in 1 patient. And we found that the time to onset was roughly about 3 to 5 years. Unfortunately, 3 of these patients lost their graft. One had a nephrectomy also done because there was some involvement of the graft with the PTLD. So this is just a small recapitulate of the fact that when we are talking about malignancies in a post-transplant patient, you would notice in this pictorial over here that the most important cause of malignancy appears to be either the time to transplant or the infections or even the overall cumulative immunosuppression. So if we are going to be discussing about PTLD, then we should know that when you're looking at a patient who's been transplanted for a long period of time, or the overall immunosuppression has been more than what the patient was supposed to receive, because there are no ways in which you can immunologically categorize a patient to the amount of immunosuppression, his response to immunosuppression, you might be heading for a problem of PTLD in a patient who presents to you non-specifically. So the pathophysiology has been very well documented and has been very well described in the previous talk, but I just wanted to bring out a small point here, that the basic problem here is that there seems to be decreased immune surveillance. So once you have a decreased immune surveillance, you will have the tumor cells that are going to multiply very rapidly, and especially if you have an infection that's coming into these cells and causes a kind of a mechanism in which these cells rapidly multiply, then you will have development of cancers. So it's not just about the development of an allogenic response, but also the immunosuppression itself. So what happens is when you're giving immunosuppression to your patients, you're basically reducing their cytotoxic T lymphocyte response. So once you have that, you have decreased T cell response. And so you're going to have a proliferation of the B cells, which have been infected by the EBV cells, and in turn you have the progression of the cancer. This has been discussed well. This is actually the 2017 classification, which described only the non-destructive, polymorphic, and the monomorphic types. And what is important here to see is that in the non-destructive, nearly 100% of these patients will be having EBV positivity. So that means that we feel that most of our patients who have PTLD should be EBV positive. But unfortunately, with the recent data that's come in, nearly 40% of our patients are turning out to be EBV negative and still having PTLD. This also has been stolen from my desktop, so I will just want to say one small thing as a nephrologist, but not as an oncologist, that I would see that the EBV positivity related PTLD is more common in the first part. So that means in the first year, if you're dealing with a patient up to the third year, then you would be having an EBV positive patient, and EBV negative is more in the second peak, which is somewhere from the 3rd to the 15th year. So you have more of patients coming now with late presentations of PTLD, and most of them are EBV negative, which obviously have a poorer prognosis as compared to patients who are EBV positive. Again, this slide has been discussed, so I will not go through this slide. But I would want to talk to you about the natural history of PTLD, which is very interesting to know what exactly happens to our patients. So your patient walks to you for a kidney transplant. You give an induction therapy to this patient, either an interleukin 2 receptor antagonist or maybe a lymphocyte blocking agent. And you probably not check the EBV of this patient in terms of what is his PCR viral load. And you have a patient who's immunologically probably quiescent EBV, and the donor is also IgM negative, and then you transplant these patients. And then this patient somehow keeps on getting episodes of acute rejection, and you keep on increasing the dose of your immunosuppression. So what happens in between is that we probably have lost the essence of checking the reason of having rejections, number one, and number two also the fact that every time you're going to immune suppress them more, you're going to be having resurgence of infections. So when we do such a thing, we do give prophylaxis for CMV, we give prophylaxis for PCP, but this is something that we've never looked into in most of our patients. And then they present to you with atypical symptoms, and then you do your histological examination, your histology, and then you probably reduce the immunosuppression, you treat the PTLD with whatever, but overall immunosuppression goes down even in the maintenance therapy, and again he starts getting rejection. So you've treated the PTLD, but here what's happened is that you're going to end up losing the graft because you've reduced the overall immunosuppression, because that's the primary treatment for patients who have PTLD in the present day literature. In the end, what happens is that you have an allograft lost. And then what do you do with these patients again? Would you like to retransplant them? So we'll discuss that in a while. So we've already discussed this, that GEIT is the most commonly involved site in a renal transplant recipient, but it is the CNS disease which is actually the most, is the one that you should absolutely fear. So most of the patients that we get in our practice are patients who come to us with weight loss, sweats, some amount of fever on and off, and very mild graft dysfunction, mostly in terms of reduction of eGFR, very less in terms of increase of proteinuria. And this is the graph again, which shows that weight loss, though, is the commonest presentation that we have, but seems to be one of the lowest on this graph. So we have fever, we have weight loss, we have some GI tract involvement in forms of patient is not able to eat well, patient is having chronic diarrhea, and then that's where you start thinking of infections, and then you further look at these patients and then you work them up. So once you worked up your patient and you've diagnosed that the patient has probably a PTLD, and you've checked your EBV status of these patients, the most important thing is to reduce the immunosuppression. And obviously there is a role of rituximab therapy, and now we have trials which have told us that if you have to maintain a longer disease-free survival, then if you add rituximab to CHOP therapy along with the GCSF, then you have better outcomes. You also have the CAR-T therapy, and what is latest is the EBV-specific cytotoxic T lymphocyte therapy. So when you're reducing your immunosuppression and giving rituximab, you are basically trying to re-establish the T cell function, and you're trying to enhance the EBV-specific cellular immunity. So rituximab is widely used as an adjunct in CD20 positive B cell PTLD, especially in those who've had an incomplete response to reduction in immunosuppression. And this gentleman over here, Trappe et al., has shown very clearly, and we've seen in the previous slides by the previous speaker also, that it has shown to improve the overall survival by nearly 27%, especially so in patients who have partial remission. Now, when you combine reduction in immunosuppression with rituximab and you get no response, then you have the option of using CHOP chemotherapy, or you use this kind of a therapy in very malignant diseases such as the Hodgkin's or the CNS involvement, in which you would like to give CHOP and you would want to combine it with 3 or 4 doses of rituximab. So there has been this study which is called as the PTLD-1 study, which has analyzed and looked at the survival of patients as well as the remission rates in these patients with a combination therapy, and have shown a very, very good response of about 70% complete response with a median survival of 6.6 years. There's another drug, brentuximab vedotin. We've never used this. I've just read it when I was making this presentation. I'm not aware whether this drug is available in our country. We'll discuss this later on. But it's an antibody drug conjugate which targets the CD30 surface marker, which is present in about 70% of patients. And look at the overall response rate. It has an 80% overall response rate with a complete remission rate of 60%. But unfortunately, it has adverse events such as neutropenia in a very high proportion of patients, and we've had the reports only up to a year or 2 of follow-up. Coming to the CAR T therapy, there is some contradictory response between multiple case studies in response to CAR T therapies. But overall, there seems to be nearly a 55% complete remission in patients who've undergone a solid organ transplant. 80% of these patients have experienced cytokine release syndrome, and 70% have experienced neurotoxicity. 14% have also experienced allograft rejection. So we don't really know the role of CAR T therapy in our subset of patients. But we do have this kind of a therapy which is called as a EBV-specific cytotoxic T lymphocyte therapy, which is essentially an adoptive immunotherapy. And what it's going to do is that it's going to suppress the reactivation of the Epstein-Barr virus. In this systematic review, there has been nearly a 66% response and 35% so in kidney transplant patients across 11 studies. It has been shown to be effective also in primary CNS PTLD, and the prophylactic role has, however, not been studied because that's a very important and very interesting arena to explore into. So just to put this in a small perspective from my point of view, when I look at a patient with PTLD, the first thing I would do is reduce the immunosuppression. Especially, I try to take off the anti-proliferative agents and reduce the dose of CNI to as less as possible while monitoring the graft function. I'd also like to look at the CD20 positivity in these patients. If the CD20 is positive and I'm dealing with a polymorphic variant, I'd like to go in for rituximab, and maybe later, maybe I might want to go in for surgery if I see that the response rate is little poor. In terms of monomorphic variants, again, if it is CD20 positive, then I would add rituximab to CHOP, and CHOP would be used primarily for CD20 negative subset. When I'm dealing with the more horrible ones, such as the classical Hodgkin's lymphoma, I'd like to use everything that I have, that is immunosuppression reduction, chemotherapy, radiotherapy, and probably maybe at some stage even surgery. So these are the future strategies. You have the Bruton's tyrosine kinase inhibition, which is ibrutinib. Then you have the inhibition of the mTOR, which is the mTOR inhibitors, which is still being under study, though they have been used and have been told to be replacing other drugs when you're looking at patients with PTLD, but we don't have good data to tell that they will stop the progression of lymphoma, though they have some role in animal studies to reduce the rates of lymphomas when they're used upfront. Apart from that, proteasome inhibitors such as bortezomib, especially in hematopoietic stem cell transplantation, checkpoint inhibitors, they have their own set of problems, as was elucidated by Mayuri, and anti-CD30 therapy is something that I spoke to you about. So now that we've had a patient that you've treated and he's undergone graft loss, so when would you want to transplant such patients? So there seems to be no clear consensus on this, but it appears that anything between 12 to 24 months from the time of complete remission of the disease is the best time that you can think of getting a retransplant done. And retransplantation is actually is not a detrimental factor for these patients, because here, since you have already cured the PTLD, it's always better to keep these patients on some amount of renal replacement therapy, and the best form of renal replacement therapy appears still to be a transplant. In terms of Epstein-Barr virus, these patients should have turned to be IgG, the IgG positivity should come back again, and there should be a low or absent EBV titer. So now the problem is, what is a low EBV titer? There appears to be no standardization on the amount of EBV titer. So now you have different serological assays in which you can actually detect the viral capsid antigen IgG levels. So if you can detect an IgG to the viral capsid antigen, then you are probably dealing with a better patient, because he has already developed a response against the EBV. Apart from that, some people have also used antiviral therapy, that is a long-term ganciclovir, but unfortunately, we don't have very convincing data on that. But what is important is the role of immunosuppression, that is the overall magnitude of the immunosuppression is the most important. So if you're using ATG in your patient again, you have to understand that you're going to trigger a lymphoma once again. So you have to be careful. Interleukin-2 receptor antagonists have a lower risk of PTLD because they somehow cause the upsurgence of the T cell activity after a while. And rituximab has been shown, as you've seen, if can be used as an induction agent, though we are not being using rituximab for induction agents in most of our patients, and published literature also has not really been very encouraging in doing so, but it can limit the EBV proliferation in lymphocytes. In terms of maintenance immunosuppression, you should use the lowest safe dose, and there seems to be absolutely no convincing evidence as of now that MMF has to be not used in these patients. So you can use a low dose of MMF in these patients and continue to do so. And mTOR inhibitors, as I've told you before, they will inhibit the development of lymphomas, but have no role as such in stopping the progression, or maybe even in reducing the progression of lymphoma. So ladies and gentlemen, to conclude, PTLD is a feared complication following kidney transplantation, and Epstein-Barr virus is an important risk factor for PTLD development, even though 40% of cases are EBV negative in modern series. The overall level of immunosuppression seems to be the most important driver for the increased risk of PTLD in our subset of patients, and older lymphocyte targeting monoclonal antibodies and tacrolimus have been specifically identified to increase PTLD risk only in a few studies. Reduction in immunosuppression is commonly accepted as a first step in the prevention and treatment of PTLD, and in recent decades, the outcomes in patients with PTLD have improved because of introduction of more uniform treatment protocols, improved supportive care, and increased awareness, as well as use of PET-CT as well as other diagnostic facilities. Repeat transplant appears to be an option after prolonged complete remission. With this, I'd like to thank you for your kind attention. Thank you very much.
Thank you, Dr. Ilanthandal and Dr. Bhargava, for your presentation.
As you can see, the problem with this is it is not a common disease. And whenever you don't have a common disease, there is a lot of difficulty in standardizing management. You cannot have randomized trials. You cannot have high level of evidence. So most of the data comes from series published by various institutions or compiled from experience of individual experts. So the key point is awareness and close monitoring, because as you heard from both the speakers, the presentation can be non-specific. So I think a lot of the improvement has simply come from the fact that we are aware of the need to be monitoring for this entity, as well as so many other things that happen in post-transplant. See, one of the points that Dr. Bhargava highlighted, when the graft is being rejected, you think of infections and other things, it could be a PTLD. So instead of jumping in and increasing the immunosuppression, maybe you should do the other way around. So that you can do only if you are aware of the fact that it could be a PTLD. I want to ask you a question as a nephrologist. Is there, there are a lot of these immunosuppressive agents used, tacrolimus, cyclosporin, and so on. Among them, is there any data to suggest that one or the other is less prone to cause this kind of problem?
Well, there seems to be no data in terms of the drug group, which is called the CNI, that is the calcineurin inhibitor group. between cyclosporin and tacrolimus, there seems to be, none of them seems to be superior to each other or inferior to each other. It's just that both the drugs have to be, the drug levels have to be maintained at the lower level once you develop PTLD. There is no protection from either the drugs. In terms of anti-proliferative, there seems to be more data in terms of azathioprine, which says that use of azathioprine has been associated with more events of PTLD. But what we understand is when you analyze such data, you also have to understand that azathioprine is a much older drug and has more patients on azathioprine as compared to MMF, which has been introduced just about 2.5 decades back. So MMF also has been studied now. And as now we have more patients on MMF now, it's the other way around. So now we have more data which is saying that you probably can use MMF in patients who have developed PTLD, and there seems to be very little evidence of MMF causing a PTLD. So these are the two kind of drugs. The third drug is what we use in transplant is an mTOR inhibitor. So mTOR inhibitors have been proposed to be used in patients to protect them against a PTLD, but not to reduce the progression of PTLD. So the common understanding that I had when I was learning my bit of nephrology was that if you develop PTLD, if you have a patient who has PTLD, just reduce the immunosuppression and put them on mTOR inhibitors. And then these patients could have either proteinuria or more incidence of graft rejections. But the emerging data doesn't support this kind of a understanding.
Thank you. I will pass the mic to Dr. Balasubramanian. Before that, I just want to highlight that our clinical expert in management of PTLD, Dr. Jose, he seems to appear and disappear every 5 minutes. But he is, I think unequivocally in this audience, is the clinical expert on management of PTLD. So I think people here should avail his expertise by asking him questions too. I pass it on to Dr. Balasubramanian.
Thank you, sir. Before we conclude this session, for the benefits of nephrology postgraduates, I would like to summarize some of the important aspects of the topic, which was already elaborated by both the speakers. So as a nephrologist registrar, what we have to remember, PTLD, you need to have a high index of suspicion. Unless you suspect, you will not be able to make early diagnosis, one. Second thing, PTLD, though predominantly 85% of the PTLD is of B cell origin, 10 to 15% arise from T cells as well as from NK cells. So the most commonly reported incidence is coming from multi-organ solid organ transplant. The highest incidence was reported with combined liver pancreas transplant. As far as kidney transplant is concerned, the incidence of PTLD is very less. Almost I would say it is the range from 0.5 to 1%. That is the thing. And most important thing, often the clinical presentation is atypical and non-specific. Whenever you have unexplained graft dysfunction, provided you have excluded all other common causes, then you have to suspect this PTLD. And another important thing regarding the management, I think Anand Bhargava has described so many options according to the classifications or the histological type. So in addition to that, the recent development with regard to PTLD in, overall, there is a phase 1 trial is going on for vaccine. That is the photochemically treated B cell immunolymphoblastoid cells, or a phase 1 trial is undergoing. This is specifically aimed for patients or recipients who are EBV negative or patients who are more vulnerable to develop PTLD after post-transplant scenario. This may be useful. The study is right now in phase 1 trial. Maybe it will give more information once we get some information after phase 3 trial, which may reduce the overall incidence of PTLD. Thank you to both the speakers, and with this we will conclude this session. Thank you so much.
Good afternoon. Yeah. Good afternoon to everyone. I know we're running late. Can I just ask all the nephrologists in the audience to put up their hands, just so that I know that it's mainly nephrologists, right? Okay, so I'll just tailor my talk that way. So, so I'm Sushil from Department of Hematology at CMC. So I think actually we straddle between oncologists and nephrologists. We have the same concerns for endothelium as all of you. So because we see benign and malignant hematology. But from the perspective of hemat-oncology, I think my talk will be mainly focusing on what we can share and our experiences and what is the learned experience of the world. And I think I will end my talk with what I hope my talk here will achieve. So the topic that I have been given and that I will be focusing on is leukemia, lymphoma, and the impact on the kidney. And broadly, to start off, renal dysfunction is common with cancer, of course. Hematological cancer in specific, there are certain mechanisms, certain pathways, and certain malignancies that are famously involved, and of which multiple myeloma is probably what everyone must have heard of by now, and all other plasma cell dyscrasias too, for that matter. It is multiple myeloma and leukemia are the first and third most frequent cancers associated with acute kidney injury, and the most common cancers leading to dialysis requirements in these patients also. So in addition to the precipitation of these monoclonal immunoglobulins as in plasma cell dyscrasias, kidney damage can be due to chemotherapy agents, and also a lot of other lesions can be caused by other than these particular mechanisms. There are lots of other renal lesions that can be caused. And so I've sort of broadly distilled it into this table. So you'll see that they could be monoclonal protein related, direct renal infiltration, paraneoplastic, or treatment related. Of these, I'm not going to talk about this because my colleague Nikita will be talking about that tomorrow in more detail. So that'll give me more time to focus on the more esoteric topics here. So that is direct renal infiltration, paraneoplastic, and treatment related. So here's a picture, again, this is, for my colleague and friend Dr. Ellen, for his sake, a few more of the pathology pictures. But just something to show that the example one that is, my point, slides A and B are essentially directly involved, a renal DLBCL for that matter, where you can see that the interstitium is markedly expanded by these atypical large lymphoid cells, all strongly staining for CD20. And another example of a direct renal involvement is by an intravascular DLBCL. And so here you can see that there is occlusion of the lumina of the peritubular capillaries, again staining strongly with CD20. So this is an obvious and very clear-cut direct intercalation of the two diseases, where you can see that there is the lymphoma or the leukemia directly infiltrates the kidney and affects the function. Coming to the more esoteric disease, which is where these hematological malignancies affect kidneys by paraneoplastic effects. And usually these are all mediated by hormones, cytokines, growth factors, or direct tumor antigens expressed by the tumor cells. And there are very close relationships between particular renal pathologies and malignancies and hematological malignancies, of which the most famous probably is minimal change disease and Hodgkin's lymphoma, non-Hodgkin's, and to some extent thymoma. The MPGNs and membranous nephropathies are the commonest glomerular diseases observed in patients with CLL, and they account for around 36% of the cases of glomerulonephritis associated with hematological malignancies. So when you look at the hematological malignancies broadly, we classify them into lymphoid and myeloid, as you might have learned from your undergraduate days. And so when we talk about the lymphoid diseases, the glomerular diseases in the form of paraneoplastic glomerular nephropathies and acute kidney injuries because of either lymphomatous interstitial or glomerular infiltration are common. The other diseases that can be caused in the lymphoid setting is, of course, tumor lysis syndrome and the effects of tumor lysis syndrome, which probably is more related to the treatment. And the hematological malignancies caused by clonal proliferations of myeloid cells are also associated with specific renal involvement, but of course much less than lymphoid. Hematological neoplasms that are more chronic, like CLL, thymomas, MPNs, Castleman's, and HLH, have also been associated with development of kidney lesions. And so again, this is a table that's from a recent review, But I think what we will focus on is broadly looking at the three major groups, which is the Hodgkin's and their involvements, the myelodysplastic and myeloid malignancies and their involvements, and Castleman, Tafro, Poems, and hemophagocytic related disorders. So you can see there's really not much to choose between all these three, though I've grouped them into three. These are more groupings in terms of their commonality. And what probably is the most striking is the minimal change disease in Hodgkin's, which is probably the poster child of paraneoplastic involvement with hematological malignancies. So just focusing on that, broadly, these are the four big players when it comes to renal pathologies in this field. So minimal change disease, MPGNs, TMAs, and FSGS. And to focus more on chronic, on the classical Hodgkin's lymphoma setting, it's been found that the most common CHL in this that causes minimal change disease is often the nodular sclerosing type. Predominated around 70% of them are actually NSHL. And IL-13 appears to be an important player in this. This was seen in almost all the patients in various mouse and animal models that were used to study this entity. And Nakayama found that tumor necrosis factor alpha was overproduced in the patients with relapsing CHL-related minimal change disease. And Audard et al., again, who actually had initially done the first study in this, had shown that a particular CMYB protein was induced in both podocytes and HRS cells. And therefore, this could explain the reason for the off-target paraneoplastic effect seen in classical Hodgkin's lymphoma. But that doesn't play down the other less known disorders, like especially TMAs that are common with plasma cell dyscrasias, hemophagocytosis, and certain amount of MPNs, that is myeloproliferative neoplasms like myelofibrosis, are often entities that cause renal TMAs. And MPGNs are seen with myelodysplastic syndromes and myeloproliferative neoplasms commonly. Again, hemophagocytic syndrome causes a very aggressive collapsing FSGS, and also which is seen in thymomas and MDS and MPNs. Going on to the broad mechanisms of injury here, I've decided to just talk about mainly the malignancy-related injuries and treatment-related injuries. It's kind of taking off from the previous topics that I discussed. So you can see here, the malignancy-related injuries are broadly hypercalcemia-related, direct tumor invasion, extramedullary hematopoiesis, which can basically come especially in MPNs and other hematological disorders. Paraproteinemias causing direct renal involvement, and thrombotic microangiopathies, as I discussed in the previous slide. When it comes to the broad entity of treatment-related injuries, which actually probably is where we both interact as hemat-oncologists and nephrologists, tumor lysis syndrome, nephrotoxic chemotherapy and its effects, which were discussed in the first session, and TMAs, again, as mentioned in the previous slide, and the various drugs that can cause TMAs, including CNIs. Everyone's probably seen this being nephrology in this, so I won't focus too much, but this is the Cairo-Bishop definition for tumor lysis syndrome, where there are laboratory and clinical TLS parameters, more than equal to 2 or more derangements 3 days before or 7 days after chemotherapy, and clinical TLS, where you can see the 3 listed, that is arrhythmias, creatinine, and seizures. These are often used to diagnose TLS, but not hard and fast, because often we have to go with just 1 or 2 of these and gut feelings when it comes to especially aggressive lymphomas and leukemias when we start chemotherapy, and go with the temporal association of the use of steroids or other aggressive chemotherapies in that setting. So yeah, some broad slides. Again, I was thinking there might be more oncologists here. So if there's, this is probably very familiar to all the nephrologists in the crowd. So this is essentially a slide just to show the various renal lesions caused by the various drugs. As you can see, a whole host of glomerular pathologies, mainly caused by the ICIs and the use, as was talked about in the first session, and how the immune checkpoint inhibitors cause sort of autoimmune damage to the glomerulus and other mechanisms, of course. TMAs, again, caused by a whole host of drugs, including the platinum-based. The tubulopathies are caused by both cyclophosphamide and its iterations, and cisplatin and ICIs. And all these as listed, as probably all of you have already gone through. Coming to the cytotoxic chemotherapy drugs that and the mechanism of action and mechanism of kidney damage and the type of damage it induces. Again, I won't go through many, but probably just focus on, I think the platinum was already covered. So maybe I'll focus on, one interesting one is bendamustine, which we use commonly in hemato-oncology. Causes an ATN and often can cause a Gitelman syndrome also. It's because of a direct tubular toxicity. Methotrexate was covered, pemetrexate covered. I think, of course, the Vinca alkaloids, as all of you classically know, can lead to the SIAD syndrome, and the hyponatremias, which are often quite life-threatening also if gone unnoticed, especially because lots of those patients are managed on OP basis. And the targeted therapies and related to them, I think VEGF was covered, multi-target TKIs were covered. I mean, there's lots of input, I think, from hematologists in those discussions, but out of the purview right now. Maybe I'll focus on venetoclax, which was probably not covered. This is a pro-apoptotic drug, BH3 mimetic, which is used now in CLL and AML very commonly. Mainly causes an acute kidney injury that is independent of the load of malignancy often, usually because of a tumor-lysis syndrome, which is dose-dependent and can be controlled when suspected. So, dyselectric, again, a slide that is very familiar for nephrologists, I suppose. We talked about the hypomagnesemia and cisplatin. We talked about hyponatremias. We talked about hypokalemias, ICIs and its effects. So I'll go through. We'll go on to transplant. This is the last two slides. I think I'm holding you back from lunch also. So this is looking at, I deal with hematopoietic stem cell transplantation. And so the common regimens we use, essentially conditioning regimens that ablate the marrow, and then the stem cells are given, they engraft, and they cause effects post-engraftment on the kidneys. So these are the effects that we will be focusing on in the next two slides. When it comes to the conditioning regimen itself, you'll notice that I've highlighted Bucy, Flu-Bu, and Beam as having a moderate risk of acute kidney injury for various of the drug combinations that are used here, as you can see. There are multiple contributory factors that we have to keep in mind during the process of SET. And they are poor oral intakes owing to chemotherapy-induced anorexia, emesis, and diuresis and diarrhea at the time of the transplant. A very likely chance of the patient being in sepsis because of the low WBC count pre-engraftments. Coexisting cirrhosis, heart failure that may occur in these patients. A whole host of medications that can be implicated as the main reason for the renal damage, including especially that all patients should be on some sort of calcineurin inhibition. Cytokine release syndrome, especially in the setting of haploidentical stem cell transplantation. And of course in CAR T cell therapy and other cell therapies also. Early veno-occlusive disease. Sort of summarized in this slide that was published quite recently. As you can see on the left of this slide, these are the problems that we face after the donor cell infusion at day 0 is. Engraftment happens within 2 to 3 weeks post donor cell infusion, depending on the kind of transplant, the donor status, and the recipient disease. You can see that acute GVHD happens in the first 100 days, then goes on to chronic GVHD subsequently. Of course, there are overlaps as per the recent reclassifications in 2015-16. And here is where the etiologies for the various kidney damages that can happen post-transplant are listed. And as you can see here, right from the marrow infusion toxicity, especially if you use cryopreserved products where DMSO is used, on to engraftment syndrome where cytokine release is the problem, post-engraftment VOD and veno-occlusive disease causing hepatorenal syndromes. These are all the non-infection related. When it comes to infection as a cause of, I don't need to mention, probably all of you have seen consults of these, sepsis, neutropenic infections, hypovolemic AKIs, prophylactic drug toxicities, especially when we're using multiple drugs to cure infections, including ampho-B and sulfa drugs. Then a BK nephropathy, which is much less common in HSCT. We mainly get BK cystitis. And of course, all of you are very familiar with BK nephropathy. And when we come to around somewhere here between the day 60, day 100, transplant-associated TMAs can come. This, of course, the TMAs that occur post-transplant could be very likely because of calcineurin inhibitors. So that's something to keep in mind at all times. So identifying transplant-associated TMA, whether it's a CNI-associated TMA, whether it's just a transplant-associated TMA, the treatments vary, the options vary, and of course, if there is underlying graft versus host disease, that complicates the whole issue. And then once we go into the post-day 100 setting, we're usually dealing with other, more rare causes, including CKDs as a result of the acute injuries that develop during the first 100 days. And then other more rare disorders, especially renal GVHD, which can present as membranous nephropathies, MCD, FSGS, just as a manifesting as just proteinuria often. Sometimes, and most of our patients with the renal GVHD manifest without any other GVHD, organ GVHD actually, which is quite interesting. And a direct toxicity of the conditioning regimens with late effects, essentially regimen-related toxicities that can, the nephrological consequences of those can rear their heads up anytime in the late transplant period too. I think this is a slide that all of you will see very commonly over the next 2 days. This is essentially a slide that lists the various causes of renal damage when cancer is involved. Broadly split into direct malignancy related, direct cancer therapy related, non-cancer related risks, including that is whether it's because of the treatment and or side effects of them, and complications of cancer treatment directly, which include tumor lysis, neutropenic sepsis, and CRS. So I'll end here, and I'm happy to take questions. This slide is essentially just to say that I hope that this conference leads to maybe the setting up of a society of maybe an Indian society or Indian chapter of a society of the onconephrology, and of which we as an institution and a department would be happy to be helping you out with. So yeah, I'll stop here.
The plasma cell neoplasm, multiple myeloma coming. Is it part of PTLD classification? Is there an association called PTLD with myeloma presentation?
So, is the question, are there plasma cell dyscrasias that can present as PTLD?
Is it considered part of PTLD?
Yeah, I think that's a very interesting question. Though it's not classically listed in your list, it's definitely considered as a PTLD in terms of its treatment. Though it's not listed as such, and probably we will not be able to label it as such. There is more and more data, especially so from MSKCC, where I was last year. They've been doing a series cohort where they've been finding that there are more and more patients that are developing plasma cell dyscrasias post long-term post-transplants. And the reason, lots of them are not EBV driven, surprisingly. They seem to be from a different pathophysiological basis. Of course, the problem with plasma cell dyscrasias is that they are diseases of elderly. And so whether it's a second malignancy that's just occurring off the cuff of the patient, completely irrelevant to the transplant, that is the suspicion. And so that's why they're trying to do large-scale oncology group-based trials and to see whether there's an increased incidence of them. Personally, in CMC, we can say that definitely we consider them as basically PTLDs when they occur, because we have quite a few. We have a case series that's going on, and hopefully we'll be able to publish our data. We have found that EBV is positive in around 70% of them. And so that leads us to sort of have a gut feeling that it is a kind of PTLD. However, there is no direct relation between, that is currently as per pathophysiology and WHO and ICC, which is the other prevailing classification for hematological malignancies right now. Both have failed to record plasma cell dyscrasias as an official PTLD. So,
allograft was removed because it went into chronic ABMR. In addition to that, T-cell mediated rejection was noted. A patient presented with hematuria. The allograft biopsy showed a polymorphic lymphocyte infiltration. What is the significance of this? And what is the prognostic thing for the next transplant? Anybody can answer. That is one question.
I'll maybe. For in this setting, as the previous speakers had said, if it is just an infiltration and it's polymorphic, we would prefer to just wait with stopping the immunosuppression initially. And if the once the renal graft is lost and confirmed loss, definitely we would want to go for a proper biopsy, maybe a repeat biopsy again.
Allograft is removed. Graft nephrectomy
It's
has
failed.
been done.
So in that setting, then I think definitely EBV status would be the core, to measure. And once we get EBV status negativity, we would want to, we would then clear for the transplant. Usually we clear between 1 year and 2 years, as the previous speakers measured, from our department. But when it comes to management of a polymorphic PTLD, we often err on the side of treating, especially if it is EBV positive. And again, we don't use CHOP so much. We prefer to use rituximab with maybe acalabrutinib, especially has started coming in. And if the graft is already lost, we are happy to use even checkpoint inhibitors and lenalidomide, which is another good drug that can sort of harness the intact immunity of the patient. But we would ensure that normal immunity of at least 6 months prior to clearing the patient for the next transplant, to at least even after we get EBV negativity, to make sure that there is a less risk of PTLD subsequently.
In this patient whom I told, I'm considering a transplant again. So should I go for a EBV monitoring and give preemptive therapy?
Right now, is EBV positive, sir?
We don't know the status. We have to.
If it is positive, definitely there's no question that we would probably give treatment and maybe even err on the side of giving like a lymphoma-based therapy. That biopsy is, I think, little bit. So if there are clear-cut clonal markers on the biopsy, we would probably go with chemotherapy. That is, we would give maybe rituximab, acalabrutinib, len, or rituximab, cyclophosphamide, vincristine, prednisolone, maybe avoiding the anthracycline. Various combinations that are available, but or just rituximab, lenalidomide. Because here we would not want to give very aggressive chemotherapy so that the chance of the patient surviving the transplant subsequently would be higher. So that's probably how we would look at it.
Thank you so much.
Maybe Dr. Jose can say something.
Yeah. Well spoken, Dr. Shushil. I just have one question. How can you avoid these renal toxicities? What are the preventive measures that you would consider? Let it be the disease or the therapy that we use, no? What measures would you suggest?
So any particular drug or disease or toxic? So it's very broad. I think as oncologists, that's a very broad question. So I think someone had on the previous session had also spoken about broad guidelines, hydration, regular monitoring. But I think one thing that I feel is important that we take ownership of a patient, and I mean, I'm maybe stepping on somebody's feet here, but as hematologists or oncologists, we take ownership of the patient, and then the final call, we definitely get the nephrology opinion. And I think it's fine if they say that, avoid nephrotoxic drugs, because then the onus should be on us to go with non-nephrotoxic drugs. And now the armamentarium, so I'm speaking from the perspective of hematology, where every day literally we get new drugs. So we are I'm fairly confident that any of our hemato-oncology diseases, we would be able to go with a non-nephrotoxic regimen. It may not be ideal, but it will be sufficient, at least as a first line or second line agent. And equally, we are fairly confident with the good nephrology backup to go with the transplant while the patient is getting dialysis, go with CAR T-cell therapy while the patient is getting dialysis. So I think the interaction between the two of us is very important. But as long as we take the ownership and don't put too much onus on you or blame you for toxicities that are we are very clear that are going to happen. I think following the broad guidelines that we have all learned during our MD days and subsequently hydration, making sure the methotrexate toxicities are not there, making sure simple things like leucovorin is available in your pharmacy before you start methotrexate. There's certain rules that we check off before every drug is given, and we respect the drugs. I think I'm giving advice like a really old person, but essentially we respect drugs, we respect the toxicities, and we respect nephrologists. I think that's where I would say.
Our next session on BMT for the nephrologists will be chaired by Dr. Chandramoleshwari Madam and Dr. Sangeeta Ma'am.
Very good afternoon to all, and thank you to the organizing committee for the kind invitation to share our experience and talk on the bone marrow transplant. A to Z for the nephrologist. So I understand that the audience, they are more nephrologists than oncologists. I'll be starting with some nomenclatures and principles of BMT, and then talk more about what are the renal dysfunctions we can encounter during this procedure. So the source of stem cell, though we call it BMT, which is bone marrow transplant, the source of stem cell from the 1990s have changed to the peripheral blood stem cells. And hence the nomenclature has changed from earlier it was collected from the bone marrow by a surgical procedure. You used to collect 200 to 300 ml of bone marrow from the patient's bone under general anesthesia. But now from 1990s, it has changed to the peripheral blood stem cells. And hence the name change from bone marrow transplant to blood and marrow transplant or a hematopoietic stem cell transplant. So it's not a surgical procedure unlike all other solid organ transplants. It's a medical procedure where the stem cells are collected like it is done in a blood donation through a apheresis, and they are transfused intravenously to the patient. So we'll be briefly, in the next 15-20 minutes, I'll be briefly discussing on the principles of hematopoietic stem cell transplant, briefly on the procedures and the indications, and we'll focus on the renal complications during the course of transplant. We'll share our experience of BMT and the renal problems during the BMT. This transplant is one of the earliest or oldest modality of immune therapy in malignancies. And as we have known that in the last decade, immunotherapy has evolved as the fifth pillar of treatment in oncology. Besides our conventional chemotherapy, radiotherapy, and surgery, immunotherapy is now the fifth pillar of treatment in cancer. Now, this all started in the 1950s when people identified the stem cell and that it can be given IV with the identification of the HLA system, cryopreservation of stem cells. The clinical program started in Seattle in 1970s, and then we had more experience with the haploidentical transplant, and then now the newer therapy is CAR T-cell, which will be discussed in the next session. So coming to the source of the stem cells, it can be autologous when the stem cells are collected from the same patient. It can be allogenic when there is a donor who is the source of stem cell. It can be a syngenic or an identical donor. It can be a HLA matched related donor, the sibling donor, which is the most common form of donor used in most of the transplant programs. It can be a matched unrelated donor, it is called a mud transplant. It can be a haploidentical donor, half-matched. Generally, there are 12 HLA loci which we match between patient and donor. So if it is 5/10 match, it is called haploidentical donor, which has, transplant, which has emerged in the last 2 decades with the use of better immunosuppression. And umbilical cord blood can be one of the other sources of cord blood, stem cell, procuring stem cells. So recently, the most common sources, besides, older times it was bone marrow. The stem cells are collected either from the patients or the donor from the peripheral blood in more than 90% of the cases. In some of the benign hematological conditions where there is a more risk of GVHD, bone marrow may be a better source. And umbilical cord blood are used when you don't have donors in the sibling or unrelated matched donor registries. Coming to some principles of transplant, how does it work? It works through, there are 2 mechanisms. In the autologous transplant, it is the high-dose chemotherapy which gives the tumor cell kill. And in allogenic transplant, it is the additional leukemia versus graft effect, graft versus leukemia effect, which will come to later. So as the dose of chemotherapy increases, there is an increase in the tumor log kill, proportionate increase, and the depth of response increases. For the dose of high-dose chemotherapy should be kept, So in the conventional doses, when you use chemotherapy, it can provide a partial response, which is 50% reduction in the tumor burden, which is a 1 to 2 log kill of the tumor cell burden. It can, with additional cycles, it can give complete response, which is a 4 log cell kill. But in transplant, we use high-dose chemotherapy, which can eradicate the tumor cells in the tune of 8 to 12 log cell kill of the cancer cells. While using this high-dose chemotherapy, we have to balance the dose between the marrow toxicity, between the maximum marrow toxicity threshold of that given drug and death from other organ toxicity. So the dose has to be balanced between these 2 thresholds. And the stem cells in the transplant is essentially the rescue for the myeloablative side effect of the high-dose chemotherapy. So though we called it stem cell transplant, it's not the stem cells which are providing the tumor cell kill, it's the high-dose chemotherapy before the stem cells which kills the tumor cells, and then the stem cells are given as rescue to let the marrow regenerate after the myeloablation from the high-dose chemotherapy. So this is the principle of the autologous transplant. We'll come to know how additional effects are seen in the allogenic transplant. So how do we choose the drugs for high-dose chemotherapy? The drug should have a, dose is the critical factor, and they should have a first order kinetics of response, that is a steep dose response effect. There is no upper limit to the efficacy of the drug. We generally used a combination chemotherapy to overcome the intrinsic resistance of the tumor and the non-cross-resistant side effects of the drug. Alkylating agents have these properties that are particularly appropriate for high-dose chemotherapy, and they are broadly active in many tumors. The common dose-limiting toxicity of these drugs are myeloablation, which can be rescued from the stem cells which we give, and we balance the dose between the other organ toxicities. So the stem cell transplant works better when the disease is minimal. Before the transplant, we try to bring all the disease burden by additional induction chemotherapy, salvage chemotherapy, and when it is in an early stage. So some of the drugs which are commonly used in this conditioning regime, this chemotherapy or high-dose chemotherapy are commonly labeled as conditioning before the transplant to condition the bone marrow, to ablate it and create a niche for the additional stem cell to go and home in. So these drugs in their standard doses are used in many of the malignancies as for curative therapies and palliative therapies. The dose which is used in high-dose chemotherapy regime can be 5 to 10 times of the conventional doses which are used in standard regimes. Example, cyclophosphamide conventionally is used 750 to 1000 mg per meter square, whereas in the high-dose chemotherapy setting, it can be 6000 to 7000 mg per meter square. In this situation, myeloablation we can rescue. The dose-limiting toxicity becomes the hemorrhagic cystitis and hemorrhagic myocarditis from cyclophosphamide. Similarly, for melphalan, it is used at 150 to 200 mg per meter square, and mucositis is the organ-limiting toxicity. The other common drugs are carmazine, busulfan, etoposide, which are the common alkylating agents, and they have their different organ-limiting toxicities. As Dr. Sushil discussed, the common preparative regimes which are used, or the conditioning regimes are used in the stem cell transplant, depending on the disease, the primary disease which we are treating, lymphoma, myeloma, leukemia, or the benign hematological conditions. The drug should be effective against a tumor, and it should be providing an immunosuppressive effect to condition the bone marrow. These are some of the common drug combination. BEAM is one of the common regimes used in lymphoma. CBV, LACE are the other regimes. In myeloma, we use mostly a single drug, melphalan, as the conditioning regime. And Buci, Bumil, Flumil are the other conditioning regime used in allogenic transplants for leukemias and benign hematological conditions. Additionally, in allogenic transplant, besides the high-dose chemotherapy effect which we have discussed, which plays in autologous, there is a graft versus leukemia effect, which is, the mechanism is through the donor T cells which are transplanted in the stem cells. In allogenic, we collect the stem cells from a donor, a healthy donor, which can be a sibling donor, a matched related donor, or a haploidentical donor. And these donors are supposed to have a healthy T cells. This T cells goes and kills the tumor, whatever we have, the lymphoma or leukemias, by a graft versus leukemia effect. The additional side effect of this mechanism of graft versus leukemia is the graft versus host disease. So when they are killing the tumor cells, they can recognize the other tissues in the body as foreign and create a graft versus host disease, which is like an autoimmune condition in the recipient. The conditioning regimes in allogenic transplant can be a myeloablative, which is used for young, fit patients and especially for malignant conditions. It can be a non-myeloablative, a little lower dose of therapy to balance the transplant-related complications in elderly patients. So this GVL effect is mediated, the graft versus leukemia effect is mediated by the T cells in the stem cells, the donor T cells in the stem cell graft. Similarly, the GVHD is also by the same mechanism. To summarize the principles of hematopoietic stem cell transplant, the disease has to be chemosensitive. We use high-dose chemotherapy with drugs which have a steep dose response curve, and the disease should be with a minimal tumor burden. So the high-dose chemotherapy is delivered in sufficient doses to destroy the tumor cells, and the hematopoietic stem cells serve as a source of rescue to replace the ablated marrow. Additionally, in allogenic transplant, an immune effect is provided by the donor T cells through a graft versus tumor activity. This was about the principle of transplant. We'll come to how the procedure is done. So very briefly, the stem cells are harvested after mobilization. That is because we are collecting the stem cells from the peripheral blood. The peripheral blood has to come from the bone marrow to the, the stem cells have to come from the bone marrow to the peripheral blood. This is done by mobilization. There are different agents which are used in mobilization, which is growth factors. Commonly the GCSF are given to the donor or the patient to mobilize the stem cells from the marrow to the peripheral blood. Additionally, there are some CXCR4 antagonists recently, plerixafor, which are used to increase the yield of the stem cells. So the mobilization is done typically over a period of 4 days with GCSF, and then the stem cells are harvested from the peripheral blood through a process of apheresis. Now, depending on the regime which we used, the stem cells can be kept at 4 degrees, or they can be cryopreserved and kept at -80 or -196 degree, depending on the storage time we need. At -180, it can be viable for 6 months, and if we need long-term storage, we use liquid nitrogen. So this is briefly the process of stem cell harvest and storage. Then we prepare the patient with the conditioning regime, the high-dose chemotherapy and the immunosuppression. This high-dose chemotherapy again depends on the disease we are treating. That's the conditioning regime. It can be over a period of 1 day to 5 to 6 days in the different combinations which we discussed. Following the conditioning regime and depending on the half-life of the chemotherapy drugs, the stem cells which are harvested and collected are given back to the patient. This is the actual transplant, the infusion, but it is not done surgically. It's given like in the IV, through IV infusion. The important part is the management of complications after this. After the stem cell graft, the neutropenia and the count can be as low as 0 for about 2 weeks, and then once the engraftment happens, the count starts rising. So there is an early period, the first 30 days, the first 100 days, and the late effects, which we'll briefly discuss subsequently. So to summarize, we do the mobilization with GCSF injections, then collect the stem cells from peripheral blood through apheresis, do cryopreservation of the stem cells if needed, depending on the conditioning regime and the time period of transplant, give high-dose chemotherapy as conditioning and immunosuppression for an allogenic transplant, and then after the conditioning is over, reinfuse the stem cell to the patient, so which is like a blood transfusion process. The engraftment and recovery, depending on the regime and the disease and the stem cell dose, can typically happen at day 10 to day 14 to up to day 20 post-transplant. Again, these graphs says that explains the process of the stem cell mobilization. We start with the GCSF. The count can go up to 50,000-60,000 after 4 days when the stem cell harvest is done and stored. High-dose chemotherapy is given. The stem cells are infused. And this is just to show that after the stem cell infusion, after the conditioning, the neutrophil count can become as low as less than 100 or 0 for almost a week. And this is the time when the patient has to be in isolation and with a very strict monitoring and all the asepsis procedure, where there is a risk of febrile neutropenia and other drug-related toxicities, where he is managed in the BMT unit. So the engraftment is defined when the neutrophil starts rising and they become more than 500, where we call the neutrophil engraftment, and subsequently when the platelets are more than 20,000 or 50,000, it is the platelet engraftment. And the time to engraftment can be from as early as 9 days to up to 20 days for different diseases and regimes. So monitoring and supportive care during this time is the key to management. Coming to the common indications for transplant is done for malignant conditions, which are myeloma, the hematological malignancies, most commonly myeloma, high risk and relapse refractory lymphomas, and high risk and relapse refractory leukemias. Some solid tumors where transplant is done, autologous transplant, is the germ cell tumor, refractory relapsed germ cell tumor, high risk neuroblastoma in children, and some cases of Ewing's and PNET. The more common indications of non-malignant disorders like aplastic anemia, thalassemia, hemoglobinopathies, and in the last couple of decades it is emerging as a treatment modality for autoimmune and inflammatory conditions also. So this slide from the Indian Society of BMT Registry shows the transplant indications in about 27,000 patients which have been transplanted in the last 40 years in our country. The most common indication being myeloma in a quarter of these patients, in about 20%, followed by acute myeloid leukemia and thalassemia and other hemoglobinopathies and ALL. So these are the few of the common indications for transplant as per the ISBMT registry, which generally is similar across the world. This is one of the data from the CIBMTR in US, a bit older, but the indications are similar: myeloma, acute leukemias, lymphomas. And depending on the region of the world, the hemoglobinopathy indication may vary depending where is the incidence and prevalence of the hemoglobinopathies are higher. Coming to briefly on the complications can be early in the first 30 days of the transplant, which are mostly infection, bleeding from the cytopenias, mucositis from the drug conditioning regime, the various GI toxicities, diarrhea, nausea, vomiting, and the other organ toxicities, again depending on the drug used, can be pulmonary, renal, hepatic, and the GVHD, acute GVHD in allogenic transplant. Some of the late complications can be late infections with fungal different viruses, infertility, organ dysfunction, second malignancies which we have been discussing, chronic GVHD, and relapse of the primary disease. These are some illustrations I'll skip. Depending on the timeline of the transplant, the complications can vary. I'll come to the renal dysfunctions which can happen during or following the transplant. And this figure briefly summarizes what are the common renal complications we can see during early period or the later timeline. It can be pre-renal, renal, or post-renal. This already has been explained in a bit detail by Dr. Sushil. So I'll just take a minute to summarize this. The risk factors can be the advanced age, comorbidities, if there is a high baseline serum creatinine, the type of the transplant, the toxicities are more with allogenic transplant because of all other complications, the immunosuppressive drug use and the higher the pill burden and the conditioning regime. Toxicities the causes can be sepsis, the nephrotoxic medications, viral infections, as we discussed, adenovirus or BK virus, thrombotic microangiopathy associated with transplant. Radiation nephropathy is less common when the TBI or irradiation, TBI, total body irradiation, is used in the conditioning regimes. Nephrotic syndrome from chronic GVHD, and renal dysfunction associated with veno-occlusive disease. So there are different criteria defined by different societies for definition of acute kidney injury following transplant, depending on the rise of the serum creatinine, the decline in the GFR rate, and the need for hemodialysis. Grade 1 to side effects are very commonly seen, can be up to 20 to 50% because of the various risk factors we discussed. The grade 3-4 side effects can lead to a mortality of up to 80% in some of these patients. Grade 3-4 needing renal replacement therapy. Some of the common causes we discussed were drug-related. The common drugs can be the cyclophosphamide used in conditioning regime, causing hemorrhagic cystitis, rarely nephropathy, melphalan, fludarabine, the nephrotoxic antibiotic, antifungals like amphotericin B, which we used in the neutropenic period, ganciclovir used for treatment of CMV infection post-allogenic transplant, and the immunosuppression, commonly the calcineurin inhibitors, can cause renal dysfunction by vasoconstriction. The drug-related renal dysfunctions are dose-dependent, mostly reversible, and rarely chronic. And the key to management is drug dose optimization. The common viral infections which can cause renal dysfunction, typically post-allogenic transplant, is the polyoma BK virus or the adenovirus. They mostly cause hemorrhagic cystitis, sometimes nephritis and nephropathy. The risk factor is the immune suppressive therapy and the T-cell depletion, unrelated donor transplant, and the treatment is reduction of immunosuppression, antivirals, and supportive treatment. Just coming to the experience from our center, we started our transplant program in Jipmer, Pondicherry in 2013, and we have completed almost 10 years of our transplant program. It's a teamwork, multidisciplinary. Our transplant unit is in medical oncology. Our pheresis is done in transfusion medicine, and then we take help from all other departments for all the supportive care which is needed during transplant. We have done 250 odd cases in the last 10 years, of which majority are autologous transplant, and about a quarter are allogenic, including half of the cases with haplotransplant. We have a 3-bedded unit, which is the limitation. Our numbers presently are about 30 to 40 a year. This is our transplant-related mortality for autologous transplant is close to, that has improved over the years, and it is less than 3%. Presently, for allogenic transplant is a bit variable, from 8% to 20% in different settings. So this old survival data of our autologous and allogenic transplants, myeloma is the commonest one. The 2-year survival in our data is 80% for myeloma post-transplant. And in the CML, some of the cases, for the allogenic transplant, we are seeing better outcomes in the CML blast crisis. We had, during these 200 cases, we had seen several renal complications, most commonly the sepsis-related AKI, drug-induced kidney injury, as we discussed with the common drugs. Some few cases of transplant microangiopathy and engraftment syndrome-related renal dysfunction. 2 cases of BK virus-related hemorrhagic cystitis. 1 patient died due to other complication. That 1 child with acute leukemia, she is a survivor. And a couple of cases of VOD-related AKI. We had published this one rare case of myeloma post-autologous transplant who developed engraftment syndrome, transplant-associated thrombotic microangiopathy, and hemophagocytic syndrome during the course of transplant, all in 1 patient, which was a 55-year-old lady and conditioned with melphalan. It's a busy slide showing the course of the transplant. She was treated with plasmapheresis, renal replacement therapy, IVIG, steroid, and all the supportive care. She died on day 36. So post-transplant, there are multiple complications, multiple causes for the same dysfunction, and all needs to be, the supportive care needs to be optimized, the drug dose balance needs to be done. In summary, transplant is a teamwork, an intensive high-end procedure with significant risk of morbidity and mortality, but it can be potentially curable for patients where there is no other treatment option. Acute kidney injury, grade 1-2 is common. About a quarter to 50% of the patient may develop acute kidney injury anytime during post-transplant. Long-term renal dysfunctions can be seen in up to 20% of the cases. Frequency and risk of kidney injury is related to the type of transplant and the other risk factors which we discussed. The causes can be multiple, and early diagnosis and appropriate treatment is the key. Thank you.
When you take that umbilical cord for the stem cells, how many years can we preserve it? Is there any duration cutoff?
So for umbilical cord blood, in the typical cord blood bank, in liquid nitrogen, it can be stored for more than 30 to 40 years. I mean, there is no upper limit of storage. You have to check viability once you retrieve it for use. The viability of more than 90% can be retained up to 30 to 40 years.
Okay. Before starting chemotherapy, I have seen in my center, they routinely do DTPA or EC scan to estimate the, to look at the GFR. But for stem cell transplant, do you do the scan?
So
or any mode of measuring GFR?
That depends on the patient's general condition, the baseline characteristic, which is if depending on the disease and the chemotherapy has received. If a patient has received platinum-based chemotherapy, which is used in lymphomas, then we do if there is a history of rise in creatinine, in the older patients with a pre-existing condition or depending on the chemotherapy regime, we do GFR by the DTPA scan. Otherwise, we go by the creatinine values.
Okay, thank you.
Wonderful presentation. I would like to congratulate you on
Thank
that,
you.
ma'am. And I know the topic is actually hematology or hemato-oncology for nephrologists, but I also want to take away a few points for the pathology sector as well, because I'm a pathologist myself. So in our center, the practice is when you harvest the bone marrow, CD34 count is being estimated before you transplant. So do you do that also in JIPMER?
Yes, that has to be done. I did not add it, it was too much in one. But the stem cell dose, after mobilization, when we collect stem cell, the stem cell dose is calculated by the CD34, which is a surrogate marker to identify the stem cell. The CD34 is done by flow cytometry.
Yes.
The generally defined dose is 2.5 to 5 million cells are optimal for any transplant. For haplotransplant, we use a higher dose of 8 to 10 million cells per kg of the recipient.
So you do it before colony stimulating factor administration and after also, or do you do it only once?
So it's done generally when we mobilize. It's 4 days of mobilization. On the 4th day, when we are doing GCSF mobilization, the peripheral blood CD34 is seen, and there are values and cutoffs to say whether it is a good mobilization or not. Value of more than 10 or 20 is taken as a good mobilization. If it is less than 10, then we additionally use Plerixafor before the day of pheresis to have a better harvest.
Thank you, ma'am.
And it is obviously done in the stem cell product for the number of stem cell.
Yes, thank you. So the other question will be to Dr. Ilan, who is the best pathologist in the hall and the only other pathologist apart from me and my junior colleague in the hall. GVHT, have you seen any case of GVHT in the kidney? Like I've seen it in the skin, gastrointestinal tract, oral cavity, mucosa and elsewhere, but have you seen a representation of GVHT in the kidney in your experience in CMC?
Generally that case goes to nephropathologist basically. So being a hematopathologist, I won't get to see that. But I have, like when I was doing all the general thing, I have seen like skin biopsies quite often coming for GVHT.
Thanks, Ilan. Just wanted to ask you something. Okay. You being my student, I cannot help keeping quiet. Thanks.
So in the 50-odd cases which we have done allotransplant, we have not seen renal GVHT.
Thank you.
As you said, skin, GI and other organs are common. Kidney is relatively rare for GVHT.
Thank you so much.
In the session is on the exciting field of CAR-T. I request Dr. Urmila Anand ma'am and Dr. Jasmine Sethi to chair this session. We call upon Dr. Alok Shetty.
Good afternoon, everyone. I think very challenging to talk between lunch and the audience, so I'll try to keep it as brief as possible. So firstly, I would thank the organizers, especially Dr. Rajiva, for this opportunity. And also, I think I'm getting to see a lot of people who may have only spoken over calls, messages, Zoom calls, and WhatsApp messages in flesh and blood for the first time. So starting off, so I think there are two parts of the talk. So the first is a quick overview on what exactly is CAR-T therapy for the nephrologist, and then what is the role of nephrologist in this whole ball game. So beginning off, so CAR-T is basically, so normally we know that there is the T cell requires presentation with of a tumor antigen with an HLA for identification and thereafter cell kill. What has been done is that overcoming this HLA mechanism and putting a specific antibody like portion like this free light chain fragment which is there to the T cell, which is basically genetically engineered to identify specific antigens on the tumor cell. So the most commonly what has been studied so far is the CD19 antigen, which is a commonly expressed over most B cell lymphomas and BALLs. And this has been trying to translate into other fields such as myeloma, where the BCMA is the antigen, or other entities even in solid tumors. This later, the CAR T cell, which is this engineered T cell, which is then infused, then undergoes replication, and there are other bystander mechanisms by which there is additional cell kill and tumor control. then briefly with the steps involved in CAR T, a lot of things are similar to what happens in transplant, to which Dr. Smita alluded to. So initially there is leukapheresis, that is the cells are collected from the patient. Here is the patient, there is no donor. This is later sent to a manufacturing unit where the T cells are engineered using a lentivirus vector, and this cell is engineered to basically identify the target that needs to be acted against, which is usually the CD19, at least in this product. And then this whole process takes around at least, like the vein to vein time would take around at least 2 to 3 weeks, depending from product to product. So that's one of the drawbacks that's usually spoken about. And then this is later, just before the time of infusion, this is sent back. Just before infusion, what is to remember that there is also conditioning that happens, that usually which is with fludarabine and cyclophosphamide. So that's a conditioning therapy. I'll come to that again later. That needs to be given before infusion, and then finally the patient receives the product. So the current approved CARs and indications are mainly in cases of relapsed refractory B-ALLs and relapsed refractory B-cell lymphomas, and more recently in relapsed refractory multiple myeloma. So what you need to know is that the current indications are mainly for, or at least the approved indications are for B-ALL and B-cell lymphomas and myeloma. So those are the current indication. The important toxicities one need to be aware of is cytokine release syndrome. The other is ICANS or CRES, either term is the same, which is a encephalopathy-like syndrome that happens. Of course, the incidence of this has come down with the use of more humanized CAR products compared to the earlier murine-derived products. And a more long-term complication is B-cell aplasia, which is like an on-target off-tumor toxicity, because the normal CD19 expressing B-cells would also be affected. So these are some of the important toxicities one need to be aware of. So what I don't know what the nephrology needs to know or what the nephrology may need to know is, I think the three important questions are: can we infuse someone with renal dysfunction? What is the incidence of AKI while this CAR T is given, and what are the outcomes? Are the outcomes similar to, say, someone who develops renal dysfunction or not? One of the most highlighted case initially is this case series of just two patients, both who had end-stage renal disease, who were on maintenance hemodialysis, who developed diffuse large B-cell lymphoma and later went on to receive CAR T infusion, where they've actually utilized or done hemodialysis during the conditioning period. So this was one. After that, I've put in a list of series where things have been looked into. So this again is a case series where they've looked at the patients who have received CAR T in each of their centers. So here, out of 166 patients, at least 17 patients had baseline renal dysfunction, but this did not affect their outcomes. But however, they did find that they had longer ICU state. So that was one of the things that they found. Similarly, some other, this is presented as a poster where they found that, again, the presence of a baseline renal dysfunction did not affect outcomes as such, but there was some increase in non-relapse mortality. Similarly here, this is a pharmacovigilance study where they did find that there's a lot of overlap in the reporting of CRS and acute renal injury by itself. So it may be difficult to differentiate many times as pure AKI. But again, there's a good percentage of patients who may develop acute renal injury, but at least more than 50, only around maybe 20% of patients, this may be irreversible. Again, this other study where they found that, again, case series from individual institutions where any AKI, that is irrespective of grade, is around 30%. However, grade 2 to 3 AKI being less than 10%. So that's one thing to know. And again, this is again where they found around a 20% incidence. And so again, this review article where they've said that there's not really much of a difference with respect to outcomes, and one can still proceed with CAR-T in patients who have baseline renal dysfunction. So I was even looking at the more recent myeloma CAR trials. Though interestingly, they have actually excluded patients with low GFR. So both the cilta-cel and the ide-cel trials have actually excluded patients with low trials. So this is actually the case with all trials, even with the ALL or the lymphoma trials. One would actually exclude all these patients who have renal dysfunction, but even so with the myeloma trials, but the real world practice is different. So to summarize, I would say, so can one infuse someone with renal dysfunction? Yes, it's not a total no. What is the incidence of AKI? So probably all grade AKI across centers is somewhere around 20 to 30%. However, grade 3 or AKI is less than 10%. The outcomes in terms of the disease are not different. However, they may have slight higher incidence of ICU stay or non-relapse mortality if they've had baseline renal dysfunction. So I think that is something to know. Then the next point is on conditioning regimen. So the most commonly used conditioning regimen before infusion is fludarabine and cyclophosphamide, which is 25 mg per meter square of fludarabine, which is usually given between day -5 to -3, and cyclo or endoxan, which is given at 250 mg per meter square, again at the same time. However, what happens is the conditioning has many effects of its own. It causes lymphodepletion, eradication of immunosuppressive cells, which may affect the CAR-T cells. If across time, fludarabine, however, has some requirement for dose modification in the presence of renal impairment. So less than 30, it's not really recommended. Other adverse effects in terms of myelosuppression, in terms of even reported neurotoxicity with fludarabine are there. So there are groups which actually use bendamustine, and which they found it to be safe and effective even in the presence of renal dysfunction. So as an institute, our unit, we, for patients with renal dysfunction at baseline less than 30, off trial this is, we are using bendamustine and instead of fluci. So the next is tumor lysis syndrome. This again, I won't go into details of TLS. So when would tumor lysis syndrome occur? This would probably, one has to consider this during the period of conditioning. So that's one time to think of tumor lysis syndrome, because though these are traditionally chemorefractory tumors, they may still have some sensitivity to any form of chemotherapy, which is fludarabine and cyclophosphamide in this case. So that's one thing to remember. So during conditioning, you may need to monitor these patients daily and give prophylactic anti-TLS measures. The other being week 1, that is immediately after CAR-T, after the infusion, especially in patients who have had significant tumor burden, say in ALL patients who are not in remission and not just MRD positive, or patients with B lymphomas who have significant bulky disease. So these are patients where TLS would be strongly considered. So looking into the trial, I mean, that's what I was saying. So even at the landmark Axis-Hill trial, there was actually one death because of TLS even before the patient could be infused. Also, interestingly, all that said and done, in one of these paper where this was a single patient who received of CLL or received CAR-T in one of the first paper that was published in NEGM, TLS was observed almost on day 21, day 22, which is something interesting. So one needs to be always aware of this TLS that could happen. Also, another thing that we always keep telling residents is that not all elevated creatinine and not all elevated uric acid is tumor lysis syndrome. One needs to look at the temporal profile with respect to therapy and with respect to the disease condition and treatment that's received. The most important being so that's TLS. The next is CRS, or cytokine release syndrome. So this is largely mediated when the T cells contact the target cells and release a milieu of cytokines, mainly interleukin 6, and which is later produced by the myeloid lineage cells. So there's a grading of CRS. So grade 1 is where it is mild, where there's only fever. When there is hypotension, becomes grade 2, or mild hypoxia becomes grade 2. And grade 3 when there is significant need for vasopressors or utilization of either HFNC or ventilatory support. So CRS can also involve the kidneys, and they can be associated renal injury. So this could be either because of the cytokines itself, which can affect tubular function. There could be third spacing of fluid, hypertension and hyperperfusion, which can cause renal injury. And there may be cardiomyopathy, which could also be contributing to this. So things from pre-renal to ATN. So this whole spectrum where CRS can work out. Can cause renal injury. So always with management of CRS, one needs to remember that sepsis is an important differential always. So I don't think anywhere across the world they've anywhere found like one marker or one way to differentiate between ongoing sepsis and CRS. So always antibiotics, avoid nephrotoxic drugs, which is a broad term to use, and ensure perfusion. So grade 1 CRS in the absence is just supportive, minimal supportive care. Grade 2 is again, one could use things like tocilizumab. So that's our most common go-to drug. Steroids are always second line in case of CAR-T because there is always an worry that the steroids may suppress CAR-T function. So that's always avoided as far as possible. Also, preemptive steroids before blood transfusion, etc. should be avoided in cases of patients who have received CAR-T actually. So tocilizumab is the go-to drug. If tocilizumab does not work, the next go-to drug is dexamethasone. So that is this. Similar to CRS is the HLH-MS or the hemophagocytic lymphohistiocytic syndrome or the macrophage activating syndrome. Much less common compared to CRS, but however can occur. More commonly, however, it seems to involve the kidney, the liver than the kidney, but renal dysfunction can also happen in these patients. The slight difference is anakinra is more commonly used in management of this compared to CRS, and even traditional definitions of HLH, the CRS must have resolved for someone to be called as HLH. So that's about most things. So CRS, TLS and HLH. So I think these three things are what one needs to know on is where probably a nephrologist would come in if there is renal injury. This is some of our own data. So this is from our phase 2 study where we've had response rates to the tune of 60 to 70% in leukemia and lymphoma patients. So our own, so grade 3 CRS though was not that common, was around 5%. And however, grade 1 and 2 was at least around 67%. So which is quite comparable to the Axicel and other trials from the West. This actually was shared to me by Dr. Rajiva. I've realized, now CAR-T is like the new kid on the block. I think everyone seems to be wanting a bite of the cake. So I think it's being tried in autoimmune diseases. I believe that this is also being tried in kidney transplant patients and those who are sensitized. So I think more and more ways or more and more indications of CAR-T therapy are probably coming up. Also, I think we should have like realistic optimism, though it's like everyone's very excited about it. Remissions may not always be durable, so definitely an exciting therapy, but with its own pros and cons. So yes, yeah. Thank you.
Thank you, sir. It was a very nice talk.
Yeah.
So just an idea, what is the around expense of this CAR-T cell therapy in your institute?
Yeah, I think thanks. I mean, at our institute currently it's around 35 lakhs per patient for the entire procedure. But I think what is the highlight has been that this in the US or somewhere in the West, it's to the tune of around 2 to 3 crores. So compared to that, because of indigenous production, it's around 30-35 lakhs for our patients. Yeah.
So you do use the one being designed by the IIT Bombay?
Yes, ma'am. Yes. Yeah.
We are also using that, and we also have patients who are on renal failure, but when they develop complications, it becomes difficult. The CRS and all trouble us a lot.
Yeah.
And the last question, of course, we keep on asking, what happens to those abnormal CAR-Ts? Because my flow cytometrist shows me those cells, they look really difficult.
Okay. No, I didn't get your question.
See, when you do, I mean, my hematologist always looks into the number of CAR-T cells they have. So we have a very good pathologist who does flow cytometry and sort of identifies those CAR-T cells.
Yeah.
I had the privilege of seeing them. They look abnormal.
Okay.
Very abnormal, and I'm a little worried. And you keep them in your body, and nobody phagocytoses them, nobody scavenges them, and then they stay on, keep on multiplying.
Yeah.
So, what do you think is the future of these abnormal cells in your impact on the immune system?
I mean, two things. One is, one definitely wants them to stay longer, because I mean, replicate and continue to provide, you know, anti-tumor effects, so that they would produce more durable responses. But however, there's always a concern of B-cell aplasia and infections. So that is I mean, it's a balance.
They look into a marker CD20, which is there in not only B cells, in many other cells.
Yes. So we are also using like PCR is another technique that can be used to monitor these patients, like instead of just flow. So to see, look at how these copies are progressing over a period of time. But I mean, though they do look abnormal, I think we need that sort of expansion is sort of needed to have sustained tumor responses. Yeah.
I think on a lighter note, when the tumors are gone, we should have an anti-CAR T antibody also. Then.
Thank you.